I'm at work, so I can't turn my
recording in progress.
Okay, that's okay. You're not in my regular class. You're a guest, so you're okay. All right. Excuse me. So I'm going to go ahead. What I do is I share a screen. I share my PowerPoints that I sent out earlier, and you follow along, write your notes. If you come across something that you're not familiar, or you forgot about it because it's been so long and you've got a lot of information since then you write it down and then you go back to it later on. Okay. All right. So I'm going to share my screen and let's study. Let's study all together, because that's what it takes. There is no magic to this. This is what my first slide says, study. And here we are as a maternity nursing, how we all come together over our patient and give a report. This will be you one day, give a report, and you want to always give a clear report of what's going on. Okay, so we're going to start with some maternal mortality or morbidity. So some frequent maternal medical risks are associated with pregnancy. Okay, and they are, as you know, hypertension associated with pregnancy, and that's called pregnancy-induced hypertension, PIH. Another big problem in maternity is diabetes. Patient comes in with type 1 and she's pregnant. It is a challenge to get her through the pregnancy with a healthy mom and healthy baby. Then you have another medical risk, which is obesity, which is your BMI 30 or greater. Again, it's a medical risk that's associated with pregnancy. And we have to get them through all this. So gestational hypertension, pulmonary embolism, and a hemorrhage are the 3 leading causes of maternal death in the United States. And we have gone over hemorrhage, haven't we? Okay, so in the beginning, we always like to get a woman in to see her obstetrician before she gets pregnant. It's called preconception care. And what we want to do is get her on the vitamins, teach and encourage her about a healthy lifestyle during the pregnancy. Remember something, healthy moms equal healthy babies. And as we discussed just a couple of weeks ago about, congenital defects and problems like if they didn't get on folic acid, the open neural tube defects, okay, such as spina bifida and hydrocephalus. So this is why we want to get them in. It'd be wonderful to get them in preconceptually. Do we always do that? No. Okay. Now, 2 substances that will definitely affect the fetus is alcohol consumption. And they are born, these infants have alcohol-related neurological disorder, and they're born with the NAS, and it is a neonatal abstinence syndrome. And it's heartbreaking to see these kids born with this. And then, of course, cigarette smoking. Cigarette smoking is a leading cause of prevention of death and illnesses. And then, of course, even a passive smoker is not good. You have, it's the same, very similar hazard for non-smoking. People do get cancer from passive smoking. So you want to keep away from all that. And that's what we teach our moms. Okay, going to start with some sexually transmitted. These are bacterial infections. So you got chlamydia, which is most common and is fast spreading. So chlamydia can affect the fallopian tubes, okay? And so women who are having problems getting pregnant, maybe infertility, you look at if they've had, what kind of history, what kind of lifestyle they have had. And then, of course, we give them doxycycline to combat it. Now, another bad infection that can occur is gonorrhea. Gonorrhea is another sexually transmitted disease or infection, I should say, and it can be passed from mother to newborn. Now, you know, a lot of times women are asymptomatic. They do have some menstrual irregular periods and sometimes some rectal complications. Again, we treat it with antibiotics, but it's good to get these women and get these cultures done to see if they have any problems. Another sexually transmitted disease or infection is the HPV, the human papillomavirus. And you see it. You may know it as genital warts or venereal warts. And we do some screening. We do a pap smear, it shows up. And what they look like little cauliflower looking warts. We do give the vaccine now. We have been doing it for a while to, it's called the Gardasil, is to combat the HPV virus. Now, HIV in the pregnant woman. Now, HESI likes to put on at least one question about HIV in the pregnant lady, okay? And so we know that from mother to infant, it goes through maternal circulation, okay? And early as first trimester. So we want to get these mothers in and start treating them so that we can help the baby. It is passed through to the infant through labor and birth. And then she cannot breastfeed because the HIV virus goes right through to the breast milk. So what we do is we put them on, you know, the AZT therapy during pregnancy. We try to keep it under control. And then again, of course, we say no breastfeeding. Now, group B streptococcus is another vaginal infection, and it has a poor pregnancy outcome. Now, we do screen every woman around 36, 37 weeks gestation. It does decrease the risk factors. And you want, if these babies are come through vagina that is positive, babies can get very, very sick. They get that hyaline membrane disease or the respiratory distress, and they can be very sick in the NICU. So what are we going to do? All right, so mom gets cultured around 36 to 37 weeks gestation. She comes up and she's positive. We can give her during labor antibiotics, okay? And during the labor, we give her antibiotics and she can have a regular vaginal delivery, okay? And of course, the baby will be watched in NICU after that delivery, but we can deliver. Now, even I know pediatricians won't even do, like if you have a patient who has an induction in labor, we're not able to do that induction until we get the group beta strep culture back. So every woman is tested. It doesn't make sense to deliver a woman who's positive and cause such damage to baby's lungs, and babies can get very, very sick. So the reason why we want to do this, we want to decrease the neonatal group beta strep infection. And so, like I said, we screen, we give antibiotics during labor, and it really helps. Okay. So again, it's very, very important. All right. So let's start here now. We're going back and talking about the embryo and the fetus. Okay. Do you remember Ava? That's an artery, vein, artery. So we have two arteries and one vein. And remember, the amniotic fluid, it serves numerous functions. And the volume is important to fetal well-being. Absolutely. When we have low, called oleohydramnios, that's low amniotic fluid, we know that it could be something wrong with the baby's kidneys. We have to look at the baby's kidneys. So we want to make sure that we're looking at the amniotic fluid and the umbilical cord. The umbilical cord supplies the embryo with the maternal nutrients and oxygen. I call that baby's lifeline, you know, because he needs it so much. So remember the development of the embryo. Okay, so it goes like from day 15 until approximately 8 weeks. Okay, and it starts to look like a little human being. Okay, at week 9, it turns over to a fetus. From week 9 to week 40 and beyond, of course, you've got the fetus, okay, until you have birth. Now, at the time of implantation, so remember where implantation occurred. First, we'll start with fertilization. Remember where fertilization occurs? Fertilization occurs, remember, in the
fallopian tubes.
Yes, okay, good. And the ampulla, A-M-P-U-L-L-A, of the fallopian tube. And then you got it, then it travels and makes its way inside that uterus. And then you got implantation, okay? And it implants, it burrows down into that endometrium lining, which is lovely, it's rich with blood, and it just burrows itself and it keeps developing, okay? Now, you have the two membranes, you have the chorion and the amnion. Now, just for review, the chorion develops from the trophoblast and contains the chorionic villi on its surface. It has major umbilical blood vessels that will branch out over the surface of the placenta. So you see how it makes its way out into the blood vessels and it goes then over to the placenta. Now the amnion develops from the interior cells of that little blastocyst and becomes the covering of the umbilical cord, and then covers the chorion on the fetal side of the placenta, and that is called the shiny Schultz. That shiny Schultz is the fetal side of the placenta. So you can see how these things, when they're developing, and the reason why I just kind of keep that in mind is, remember we talked about chorioamnionitis and all that, that she can have those inflammation, and baby and mom gets very, very sick. Okay, so here's your HESI hint, and they like to do this. I've seen this over and over again. So ovulation occurs approximately 14 days before the next menstrual cycle. They always like to put a scenario with ovulation. So they usually talk, and they'll say 28-day cycle this woman's having, and the nurse will counsel the woman as to what day ovulation occurs. Okay, and then you would know about 14 days before the next menstrual cycle. So 14 days, day 14. And I just put in here for you to review just the menstrual phase. Again, day 1 through day 5 of the cycle, shedding the endometrium. Remember, we're shedding that beautiful lining. Well, if there's no pregnancy, then that lining sheds off as the period, okay? Now, day 5 now. So now she's at day 5 to day 14 with your ovulation. During this time, you're having this, what we call this ovulatory phase, and you have, remember FSH, follicle stimulating hormone, and that's secreted by the anterior pituitary. And then you have the luteinizing hormone that converts the follicle to a corpus luteum, which produces progesterone. Remember, what hormone maintains a pregnancy?
Is it progesterone?
Yes, you got it. Exactly. So, ovulatory phase. Now, this little time occurs about 2 days prior to ovulation. So, if I say ovulation is on day 14, so 2 days beforehand, it's like day 12. And what happens is a marked rise in the luteinizing hormone and the follicle stimulating hormone. So, ovulation, that time, it marks the beginning of the luteal phase. This is when what? A nice mature follicle ruptures and the ovum is released from the ovary. Bingo, it's time. You know, she might have a little bit more discharge coming out of her vagina because she's ovulating. It's now this mature follicle is ruptured. It's going to travel through that fallopian tube. Now she has intercourse during that time. The sperms, one sperm meets that ovum, bingo, she is fertilized, okay? And so, and then it travels to the uterus. Okay. So that was a quick review on that, but that's what you have to remember. So here we go. Here's your fertilization. So fertilization is when the sperm joins the egg and fertilizes it. Okay. So here's all your little follicles. All right. Then the normal sperm is presented in the cervical mucus, and the fallopian tubes, they're wide open. It's for those sperms to come up. And then you have your adequate progesterone, because you need progesterone, and you have your secretory endometrium. That means it's all ready for the zygote. And then there's adequate semen. Yeah, that all takes place. You know, if a man doesn't have adequate semen, there's a problem with a woman won't get pregnant. So that's a problem with infertility. And it's greater than 60% are normal, and the greater than 50% are motile. So we're looking at sperms here. Okay, just a quick review. So this is a really good picture. It shows you what happens. She's ovulating. Okay, here's your follicles. Here she's ovulating. Ovum gets released, and here, right in here, here's your little sperms. Takes one sperm to get into this egg, okay? And then she's fertilized. And then here you can see my, cell division that keeps cell dividing, and we get into the upper portion of the uterus on the posterior wall. Then you have your implantation. All righty. I've already gone over this, but it's just going over conception. So we just went over that already. I'll go here. And another slide was on implementation. Okay. All right. So here's your, I don't know, remember fetal development? You have the zygote, and it's a time from fertilization until it's implanted in the uterus. And then he turns in from a zygote, he turns into a little embryo. And this goes from like week 3 to week 8 after fertilization. And they go under, a lot of changes. And if mom maybe has a virus, remember we talked about chlamydia or gonorrhea, it can act like a teratogen, which is not favorable to the embryo, developing embryo. If mom gets exposed to drugs, if she takes any kind of drugs, those drugs will affect that embryo. Radiation, when we talk about infections and viruses, these all can cause congenital anomalies, okay? So a lot of times in the beginning, we don't even know, a woman doesn't even know she's pregnant, And so during that time, she can be drinking alcohol, taking drugs, or be exposed to things that can act as a teratogen to this embryo. Okay. And then the baby comes out with congenital problems because of what happened in the embryonic development time. And then you have your fetus from week 9 to all the way to term. And usually after week 9, there's fewer abnormalities that are caused by teratogens. But if mom keeps smoking or drinking alcohol, that would definitely affect that fetus at birth. Okay, these are just some tests that can be ordered during the pregnancy to check for any kind of chromosomal problems. So the CVS, which is your chorionic villi sampling, that occurs like week 8 to week 12. We can do that test. And what we're doing is remove a small piece of the villi, the tissue inside the endometrium. And we do this all the time, guys. We do it under ultrasound guidance. We just don't go in blindly. We make sure we have ultrasound guidance. And the test is done, and it's a good test. And it's 1 week. Now, does it come with risk? Yes. Just like the amniocentesis, it comes with risk. And the risk is that she could start bleeding, she can abort, and that would be awful to the mom. Amniocentesis is done a little bit later, about 12, 13 weeks. And because you have to have, we're going into the inside the uterus to get some amniotic fluid out. So it has to be enough amniotic fluid inside. So that's why it's done a little bit later than, say, the chorionic villi testing. And this one takes time. Now, I've seen HESI put a question about how would you talk, how does the nurse communicate to the parents who just, or who are waiting for the results of an amniocentesis. And remember, you always want to use therapeutic communication. You know, yes, it does take time to get those results back, but you want to make sure that, you know, you have the optimal result, okay? Because this is really, really important, because an amniocentesis done in the beginning of pregnancy is done for chromosome analysis. Now, I have seen a HESI question where they wanted to know, you know, about amniocentesis, and if it's done in the beginning of pregnancy, why is that being done? And the beginning of pregnancy is done for chromosome analysis. An amniocentesis can be done later in pregnancy, like at 36 weeks, or not even earlier, in case if we have a pretermer, say around 32, 33 weeks. And the reason why we do it that time is we're looking at the baby's lungs to see if the lungs are mature enough for us to deliver this baby. So that's the difference. So we can do an amnio in the beginning, okay, and that's for chromosome analysis. If we go through the pregnancy, everything is good, and then she goes into preterm labor, okay, and it's, you know, we try to stop them, but we can't stop her. And sometimes what we do is we do an amniocentesis to see how these babies' lungs are doing. They have enough, you know, surfactant in there to sustain them. Okay. Let's move into warning signs during pregnancy. What HESI could do is give you a scenario with all these, you know, or some of them, per se. It's never good to have bleeding or leakage of fluid from the vagina. Okay, this is during pregnancy. You know, if you have it too early, you could be aborting. If you have late pregnancy, bleeding in pregnancy, that means you have placenta previa, or you could have an abruption. So you have leaking of fluid, that means your bag of water broke. You have it too early, again, you could be aborting, and if you have it later in pregnancy, then you're apt for more infections, and we have to watch them carefully, and then most of the time, have to deliver them. So that's never good. Now, blurry, impaired vision, that could be, that happens, during preeclampsia, blood pressure. Somebody comes in with blurry vision, especially after week 20, and you gotta be worried about preeclampsia. Unusual severe stomach pain or backache, that could be UTI. So remember, urinary tract infections in a pregnant woman is never good. Okay, that's why at every OB visit, we test to see if there's WBCs or nitrates in the urine, because we do not want her to have a UTI. Because UTI, what happens, it can lead into preterm labor, because when the bladder gets inflamed, which it does with a UTI, it then makes the uterus contract, because the bladder is laying right underneath that uterus. So then you have to make sure that, you know, she doesn't go into have a UTI. Frequent, severe, or constant headaches, that could be associated also with preeclampsia. Contractions, we don't want that uterus to contract during pregnancy. When we want it to contract is at the end of pregnancy. When she becomes term, then she starts contracting. So contractions too early lead into preterm labor, and then preterm labor equals preterm babies, and then these babies have a rough time, you know, growing and surviving in the NICU. Anytime you have a decrease in baby movement after 28 weeks is a warning sign, okay? So we want the mother to come in. A lot of times they'll say, get a glass of cold water, see if you can wake that baby up. Lay on your left side, put your hand on your tummy. This baby still not moving, you get to the hospital right away. Dizziness, excessive vomiting and diarrhea. That could be from hyperemesis gravidarum. Remember that? Okay. And so we don't want her to have excessive vomiting because then and diarrhea, it all leads to electrolyte imbalance. Okay. And which is never good for a pregnant woman. Fever, chills, she could be having an infection. And so this is never good. This is a warning sign. Swelling of the face, fingers, and feet. Those are signs of what? Preeclampsia. Okay. And then inability to tolerate food or liquid. That again could be your hyperemesis gravidarum. And then your muscular convulsions. Convulsions are never good. And you start getting convulsions, you think of what the blood pressure is. Again, preeclampsia. So, and what do we give while we're talking about convulsions and seizures?
Magnesium sulfate.
Yeah, thank you. Okay, so now you're giving this lady magnesium sulfate. What do you have at bedside, just in case she gets too much magnesium?
Vitamin.
What's the antidote?
Is it calcium?
Yeah, calcium gluconate. You got it. Okay. Yeah, so I'm going to, and if you have a, since we're here, if you have a patient who has got preeclampsia and you're giving her magnesium sulfate, and of course you're checking what her reflex is, right? Okay. What else do you have to make sure? What's your nursing actions for this poor woman?
Safety.
Okay, safety, because HESI always looks at safety. So I'm going to have a padded side rails, right? Safety. Make sure her head doesn't hit the railing of the bed. I'm going to give her a nice, quiet, low stimulation room. All right. Always, I'm going to maintain airway. So you make sure that she's on her side, maintain her airway, and have the pulse oximeter on. And as soon as she comes out of the seizure, you want to go ahead and basically you're always monitoring fetal heart times. Okay. All right. And another bad warning sign during pregnancy would be what? Having thoughts of harming yourself or your baby. Yeah. Postpartum depression. And when you hear voices happening, what's that called?
Psychosis.
Yeah, postpartum psychosis. Those are all, these are, again, these are warning signs during pregnancy that you're always on alert to. Okay. All right. So a good question on HESI too, is they always like to put is about weight gain. So for the normal height, and they'll tell you as a normal height person, the total weight gain should be around 25 to 35 pounds. Okay. So, and then usually it's like 2 to 4 pounds the first trimester. Now, a lot of people don't even gain this the first trimester because of why?
They be sick.
Yeah, remember they have that nausea, vomiting. Okay, just normal nausea, vomiting. I'm not talking about hyperemesis gravidarum, just normal vomiting. So usually that's the hardest trimester. Remember, the pregnancy has 3 trimesters, all 13 weeks. And so the first trimester is usually a very confusing and hard trimester. So they don't usually gain too much because they have that nausea, vomiting, and a lot of ladies are in the bathroom a lot and they go, oh, they have a lot of ambivalence also during the first trimester. And then after they get through that, usually around week 14, it gets a little better. That's because the hormone progesterone seems to be the hormone that's the bad culprit. So when I'm practicing, And my patients, tells me, oh man, I get up in the morning and I vomit, and then I go pretty much during the whole day, and then in the evening it hits me again. I said, well, that's a good sign of a good pregnancy, a sign of good progesterone. And they go, okay. Again, I try to find the positives in everything. All right, so here's your nutrition assessment in case that you got a question about nutrition. Remember, nice, that one plate, that myplate.com. That's always a good place to go. It has good protein and everything. If when I'm counseling somebody, I usually have them do a little diary on their diet. Okay. And then we can look at it and say, well, you have a lot of more carbohydrates than say protein. All right. And in case HESI, sometimes they do is they put a BMI, guys, on there. Like the patient has a BMI of say 19.2. Okay. And she's of normal height. What would be her normal weight gain? Something like that. And so you would know a normal height, and she already has a BMI of 19.2. So that means she's normal. So she's a healthy weight range. So then you can answer the question accurately. So that's how they do it. Okay. And then I just put in here some symptoms of malnutrition. It's always those cracked lips. Oh yeah. And inflammation of the glottis, and then dry, brittle hair tells me that they're not getting enough vitamins. Okay, so then I just asked, why are you taking your vitamins? All right, so there's always a question on GTPAL. Okay, so I know in your book, in HESI book, page 181, it goes over the Gravida, and the Para. And so Gravida refers to any pregnancy and to the number of times a woman has been pregnant. Okay. Now the Para refers to the number of pregnancies that have reached 20 weeks or greater. So, and remember, twins are what? One pregnancy, right? Okay. All right. So post dates or post term, the pregnancy that goes beyond 42 weeks gestation. And then term is the beginning of week 38, and then goes to the end of week 42. And then you have preterm, which is from 20 weeks, which is considered viability to 36 and 6/7 weeks. That's how we write it. And then you have viability. And what viability means, it's just the capacity now for that fetus to live outside of the uterus. It's usually around 20 to 25 weeks. Now, when I work labor and delivery, we use 20 weeks as viability. So what happens is that, I get a phone call, say from the ER, and they say, hey, Irene, I got a patient here, she's bleeding, and she's pregnant, she's bleeding. I'll say, well, how many weeks gestation is she? And they say, oh, she's 18 weeks. Well, there's nothing I can do with that baby, okay? It's too young, it's too immature. So that's where the cutoff comes in. So when going back to Gravida and Para, so make sure that when you have a question about that on HESI, just write down on your scrap paper, GTPAL, okay? And Gravida and Para, and then GT. So you got Gravida, and then you got term, GT, P is what? Premature, right? A is abortion or miscarriages. L is how many living children she has. If you write it out like that, then you just read the little scenario and you can start to plug it in. Now, do me a favor. Don't forget the present pregnancy. That's what I see a lot of, is that students forget about the present pregnancy. So, and then you'll be fine. You'll be able to figure that out with no problem. Okay, so let's talk about pregnancy tests. So the earliest test that we have is what? HCG, the human chorionic gonadotrophin. All right, and can be detected as early as 7 to 8 days after ovulation. That's pretty good. Okay, so again, the HCG, human chorionic gonadotrophin. Alrighty. Okay, so these are your signs of pregnancy. And I know we've gone over these before, but just reviewing. So, presumptive. Remember when I was teaching before is that the U presumptive is these are you. These are what changes felt by the woman, you. So just think of that. And then you got amenorrhea, fatigue, and breast changes. I'm feeling, if I'm pregnant, I'm feeling these things. It's me, it's you. Now, probable changes that observed by an examiner. So if I see, when I go in and I see like a real bluish looking cervix, what do I think? What am I looking at? That's called the what? Chadwick sign. Chadwick sign. I got my sterile speculum in and I'm taking a peek and I see this really bluish, reddish bluish cervix. Ah, she's pregnant. That's probable. That's by the examiner. Another thing is called the Hagar sign. And that is, we go in and we check and we feel the softening of the lower segment of the uterus. That's called the Hagar sign. Now, a positive sign. Now, that's probably really obvious, folks, okay? Because these other signs, something else could have caused it, especially the presumptive. If she has amenorrhea, well, maybe she just skipped a period. If she has nausea, vomiting, well, maybe she's got a stomach flu. You get what I'm meaning by this? But positive sign is something that, hey, we do an ultrasound and there's a fetus. Okay, you see this little guy in here? That's a fetus. And so that's pretty positive. If as a practitioner and I have my hands on her abdomen and I can palpate fetal movement, that's pretty obvious. Okay, so, and then of course, if I hear fetal heart tones, that's pretty positive. So does everybody have the difference between presumptive, probable, and positive? Okay. Now here I put a picture, and here is the Hagar sign. And so what we do, this is how we do a vaginal exam. And so my one off hand is on top of her belly. And then under here, I have my sterile hand inside. And here I can palpate, I can feel, okay, I'm feeling here in the lower uterine segment, it's really soft. Okay, it's a big change. All right, she's pregnant. All right. So these are just changes related to a fetus being there. So you have these terms. So one is called ballottement. What is ballottement?
Bouncing you.
Go ahead.
Like, I think like a bouncing back on the
Yeah,
finger.
it's floating, isn't it? It's floating there. Yeah, it's called ballottement. That little baby is floating there. How about quickening? What's quickening?
That's kicking. The baby's kicking.
Yeah, a little fluttering. Oh boy, when that happens, I tell you, she may be, it's like, oh, I don't know, I want this pregnancy and blah, blah, blah. But when she feels that little flutter movement of that fetus, bingo. They adapt so quickly because they feel the baby. Okay. Yeah. And what about lightning? It's coming down, guys. Baby's head is engaging back into the pelvis. And so these are all changes that occur with the little fetus. All right. Some more changes, enlargement. We measure frontal height. So we measure from the symphysis pubis, right? Straight up. And we go up to the fundus of the uterus. And we can measure. We measure from the height. So when we measure from the height, we can tell if this baby is small or large, right? We can see if the baby's growing like it should. If she is 26 weeks gestation, how many centimeters should she measure? 26 weeks.
26, 22 to 28.
Yeah, so if 26 weeks gestation, she should measure 26 centimeters. That's how we can tell if their baby is growing, just according to how many weeks she is, okay? And maybe a question on HESI would be about the procedure, where you measure from, and maybe what the significance of fundal height is. Pretty good. Yeah, you want to, we can really tell if the baby is growing the way it should. All right, now also on the other hand, get this, good pickup. If baby is larger, so say she's supposed to be 26 weeks, right? But she is measuring, say, 30 centimeters. Okay, that's a big baby in there, all right? So I can now send her for an ultrasound to see what's going on, to see, all right, we got a large baby in here. What's the reason? So maybe, is she diabetic? And we haven't done a blood test. Maybe we go do a blood test to make sure. So fundal height is a great way to know if the fetus is growing like it should. Okay, fundal height. Now, Braxton Hicks contractions are those irregular contractions that can be very annoying, especially when you get to be term and you want to go into labor and you get all these irregular contractions. And they're annoying. They're painless contractions during pregnancy. They just I tell you what they do. They make your patient tired because she's having these, but she's not having any cervical changes. There's no dilation, there's no effacement. They're called Braxton Hicks. Okay. Now, the uterine placenta blood flow, it really is important, because when there is a deficiency in this, it can cause the fetal heart rate to go down. So you want the uterine placenta flow to keep going just good. Increase rapidly as uterus grows. Remember, during pregnancy, a woman's blood supply increases like from 40% up, even up to 50%. There's a lot of blood flowing through, because baby needs it. Baby needs oxygen. So there's oxygen in that red blood cell. So we want to have more blood circulating through mommy, because the uterus requires a lot. It does. So it has to increase because the uterus needs it. Her heart needs it. All her organs need it. So that's why it increases. So the body is quite efficient in that. Okay. All right. All right. So another cervical change in the reproductive system is called the Goodell sign. Goodell sign. Well, this is softening of the tip around about the 6th week. And what happens is just, again, there's increased vasculature. And we call this like the red velvet. It has looked like a red velvet, velveteen appearance. And just softening about 6 weeks. So there's some signs that this is happening. I talked about the Chadwick sign already. It's a deepened color of the vaginal mucosa, the cervix. And I'll tell you why, guys. The cervix is a very vascular area. It changes with the color, because more congestive. It gets real congestive in there. And so you see this different changes. She can have leukorrhea, which is white or gray mucus discharge, and the mucus plug, or opalarium mucus plug. And the mucus plug has a significant role. It's a barrier that's there. And what happens, it keeps the bacteria from ascending. Now, remember, in a woman, when bacteria goes into the vagina, it goes up. We call it ascending, it goes up. And what happens, then it makes the pH secretions all acidotic, and she can get infection. And so what happens is that mucus plug is a great barrier to keep that bacteria from going upward. Okay, so yes, it is very mucousy also. And then she does lose that prior to going into full-term labor. All right, so in the cardiovascular, what I want you to remember is blood volume. I told you 40-50% increase. Her cardiac output increases too, all right? And so you have to remember, if she has any kind of pre-existing heart condition, that is going to cause more problems to her cardiac output because of her condition. So you have to keep that in mind. Now, what I want you to remember is what? We're going to keep her on her left side, because we want to avoid supine hypotensive syndrome. You never put this down. You never put a woman on her back, okay? Her blood pressure will definitely decrease, and she'll feel dizzy, lightheaded, and she will not feel good at all. So you get her on her left side. Remember, we talked about that always in labor, put them on the left side. All right, now we have some skin changes in pregnancy. So we have that chloasma, which is the mask of pregnancy. It's kind of blotchy looking, and it's just hyperpigmentation of the skin on the cheeks, nose, and forehead. So what happens is, after she delivers, this will go away, okay? Now, the linea negra is another, that's that line that goes straight from the symphysis pubis straight to the fundus midline, goes straight up, okay? That also will go away. The striae gravidarum, these are stretch marks. These don't go away after pregnancy. As you get much older, they do turn into silver, but they don't go away. It's because the skin was stretched beyond its capacity. And so now it's stretched, but it left a mark, okay, where it was stretched. And then you have angiomas, which are vascular little spider veins, okay? And then on the palm of your hand, you could have a little bit pink or red splotches, okay? Erythema. All right. Now, under GI, her appetite, it does change. A lot of times that they have food cravings, or non-food cravings, I should say, and that's called pica, P-I-C-A. They like dirt, they like clay, some people like starch, is non-food, and it does happen. I know a lot of people, one of my friends craved dirt, okay? And so yeah. So it's called pica. And that could be on HESI also, by a little scenario, and you would know that's pica. It is normal. It's normal, it happens, but we don't want it to happen, but it happens. Okay. All right. And then you have nausea, vomiting. And thank goodness it doesn't have a lot of harmful effects. It's just that we have to find out what she can eat. Like giving her ginger, all right? I know HESI likes ginger, giving her ginger. Like ginger ale, my patients love ginger ale. I tell them to stir it first, get all the fizz out, and just sip, all right? Just sip. Just get some kind of nourishment in for the growing fetus. You're at the esophagus and the stomach and the intestines. They all have decreased tone of the smooth muscles. And what happens is that woman feels like indigestion, reflux, that esophageal reflux, and it's slower to empty. Her stomach doesn't empty like it does. So what are you going to do? Tell her to eat small meals, right? Yeah. They start eating small meals, smaller frequent meals to get the nourishment in for the fetus, but not to get overly full, because then they just vomit it up. And then you have the gallbladder and liver. They have the increased emptying time, and a lot of ladies have problems with gallbladders during pregnancy, and sometimes we have to take them out, but we do surgery. And then hemorrhoids. Okay, hemorrhoids are not, they're varicosities in the anal area, and they cause a lot of discomfort. Believe me, a lot of discomfort to the pregnant woman. And then she could have some abdominal discomfort. Remember, the uterus was down in the pelvis, right? Okay. And around week 8 to 10 weeks, but usually about 10 weeks, now the uterus grows out of the pelvis and becomes more of an abdominal organ. Okay, it's a temporary abdominal organ. And so now it's going to keep growing. And so it can cause her to have discomfort in the abdomen. It causes a lot of times shortness of breath because the abdomen, the uterus is pushing everything way high. Okay, and so it can cause some discomfort. Your endocrine system, progesterone, was the hormone that maintains the pregnancy. We talked about that. And we talked about that urinary system analysis. You know, bacteria is in the urine is not normal, is abnormal. Right? Ketones are not supposed to be. Okay. Protein in the urine, abnormal, associated with what? Preeclampsia. And glycoluria, it has a variation of normal, put it that way. I always, my patients came in and they had glucose in their urine. I say, what did you just eat? Especially if they have the first visit in the clinic after lunch. I said, aha. They said, oh, no, I'm not eating anything wrong. You know, I just had, you know, blah, blah, blah. I said, well, you have a lot of glucose in your urine. And they go, oh, I just had a Snicker bar. Okay, well, that just tells me exactly. Or they had a glass of orange juice just prior to coming in. All right. Now, here it is. UTIs are very common during pregnancy. We don't want the woman to have a UTI. That's why we check all the time for WBCs and nitrites in the urine, because we don't want her to have a UTI, because that goes into preterm labor. Now, I'm going to tell you, HESI always has at least one Nagel's rule. Okay, so you determine the her due date. Okay, so how are you going to do that? And you just you take the first day of the last menstrual period, and then you subtract 3 months, and you add 7 days. Okay. Now, of course, if it's going to turn over the year, you want to add the, add the year, But the rule is, all it is that you take the first day. Now, write that down, because that's where a lot of students go wrong, and they don't read it right. And so you want to make sure that you select it's the first day of the last menstrual period. And you subtract 3 months, and you add 7 days to this first day. Okay. So if you're struggling on that, go into your HESI book, and it's on page 181, and it's right there for you also. Okay. All right, let's talk about true labor and false labor. All right, so true labor, you do have contractions. And remember, frequency is what? How often they're coming. So you start from the beginning of one contraction, counting it, to the beginning of the next contraction, correct? That's frequency. Now, you're the labor room nurse or your triage nurse, and you say, well, how long are the contractions? You are referring to duration. How long one contraction is lasting. 1. So that would be from the beginning of one contraction to the end of that one contraction. Just one. That's duration. How long does one contractions last? All right. So we have contractions. So your patient tells you, I'm contracting every 2 to 3 minutes, and they last, nurse, 60 seconds in duration. Great. Okay. They're regular contractions. They're becoming stronger, and they lasting. Their duration is great. It's lasting at least 60 seconds in duration. Good. So when you're in true labor, your contractions are usually felt in the lower back. And that's because the baby could be in what we call occipital posterior position, where the back of his head, okay, occipital posterior means the back of his head is facing mom's back, okay? And that means his head is like up in the air, you know? And so OP, she can labor, is a hard labor, guys. It's very painful labor. And then when she's ready to push, she has to push a baby that's like looking up in the air, you know, with his chin up instead of being tucked down. The position I like for delivering a baby is occipital anterior, where the back of the baby's head, occipital, is to mom's front. Okay. Now, in true labor, you know she's in true labor because you have cervical changes. You have dilation and effacement of the cervix. So you triaging, you know, and so before you send her out walking, you make sure her vital signs are good. The baby's heart rate is between 110 to 160. That's good. You checked her. She was 2 centimeters, 80% efface, and a 0 station. Okay, all right. You sent her out walking, and her contraction became more regular, became stronger. You check her, and now she's 4 centimeters, 100% efface. And the baby's at a 0 station. She's in labor. Got it? So you have to have cervical changes to know they're in labor. And of course, when they're in true labor, the fetus will start to make his way down. So remember the station of the baby's head. 0 station is at the ischial spine. Above that is all minus 1, -2, -3, -4, and everything below that 0 station is +1, +2, +3, +4. So when she is in labor, it starts to descend. The baby starts to come down. And that's always a good sign. All right. So if I was to compare true labor and false labor, the difference is the contractions are irregular. They're not regular contractions. You know, and remember I talked about those Braxton Hicks contractions, those irregular contractions? This is where it comes into play, because this can be, you know, they think they're in labor, they come in, and meanwhile, contractions could be, say, when I say irregular, I mean like maybe one is 5 minutes, the next one could be 7, the next one could be 10. Is not rhythmic, okay? When I send her out walking, the contractions dwindle. They actually get, walking actually makes those contractions go down. So relieves the contractions. With false labor, bloody show usually is not present. Now, bloody show is mucus and blood mixture. Remember I said the cervix, it's a very vascular area, okay, very vascular. And so when it starts to open up, to dilate, open up, you're going to have some of that sloughing off of blood. And it comes down, and it comes with mucus, because there's a lot of mucus there, because when you go into labor, you have a lot of mucus. Well, that's usually not present in false labor, because the cervix has not opening up. And the biggest thing is no change in effacement and dilation of the cervix. You know, you send her out walking, she was 2 centimeters. She goes walk for a while, she comes back, and you check her, and you say, Well, you're still 2 centimeters. She'll look at you like, "Ugh," you know, she want to get you, but she's not in labor. She's in false labor. Okay, so that's the difference between false labor and we just went over true labor. Okay, so these are some nutrients that mothers need during pregnancy. They need good vitamins. You know, those prenatal vitamins, they got everything they need in those prenatal vitamins. So we want to make sure they get some good minerals, good vitamins. You want to make sure they get folic acid. Now, HESI may put a question on about vitamins, about folic acid. You want to do that in order to combat the occurrence of an open neural tube defect, such as spina bifida or hydrocephalus. And then you got vitamin pyridoxine and vitamin B6, vitamin C, vitamin 12. These are all water-soluble vitamins. And then you have your regular vitamins. And then, you know, taking too much vitamins can also lead to congenital malformations of a fetus. So we don't want to take too many. So we just tell them, just take 1 a day. Okay. And you know, a lot of times my patient would tell me it makes me nauseated and I'm not going to take them. But we have to get it because I know she's not eating enough to get all the vitamins she needs for the fetus. So I'll say, do me a favor, take them at night. Take them at night and then go to bed, and you can bypass a lot of that nausea, vomiting. Okay. We talked about some food cravings already. We talked about pica. And we talked about ginger. HESI likes them about morning sickness and using ginger. Because ginger, I mean, you can buy it over the counter. It's a nursing can, you know, say you can take that for your morning sickness. We talked about pica. Okay. All righty. This is some antepartum testing. So what we want to talk about here is just the daily fetal movement count. All right. So we want to make sure that this baby is moving because, you know, babies do sleep. They sleep like 10 to 20 minute intervals. Mom could be taking a depressant medication that's maybe making this baby sleep. Smoking can decrease fetal movement. So we have to basically ask mom what she's doing because babies should be moving like 10 movements in a 12-hour period. And no movements felt within a 12-hour period, we have to make sure that they come in. I always tell my patients, if you know your baby's sleep cycle and you know when that baby is waking and it's not doing, yes, you come in. Because moms can recognize 70, 80% of the fetal movements. And they move a lot, you know, especially in the 3rd trimester. You know, they put their arms up, their legs, and they always seem to be moving. So we want to make sure that they are moving. Okay. Now we can do a non-invasive antepartum assessment. It's by the electronic fetal monitoring. So she comes in and we can do a non-stress test. Okay. And this here, you put the monitor on, okay, the ultrasound transducer in the toco, and you give mom a little buzzer. And when she feels the baby move within 20-minute period, she's got that little marker, boom, boom, boom. You want to see what the baby's reaction, what the baby do. Heart rate should accelerate during the movement. So what we say for our criteria is that you want to have acceleration of the fetal heart rate 15 beats above your baseline lasting 15 seconds. So what I mean by that is you have a baseline, say, of 120. Okay, all right. And when the baby moves, his heart rate goes up to 135. And it lasts like 15 seconds. All right. And then it comes back down to baseline. Okay. And then baby moves again. Mom presses the little buzzer. Heart rate goes up. to 135 from baseline 120 and comes right back down. Bingo, we have a good test. That tells me that the baby is okay inside, that we're neurologically fine, and that his heart rate went up during the movement. And sometimes, we have to give mom a glass of cold water to wake this baby up. If she's not diabetic, sometimes we give them orange juice. And when you take the orange juice in, baby moves, okay? And then sometimes we have to use this acoustic stimulation, and all that is like a little buzzer. And we put, and baby's not moving, we take the little buzzer and put it on mom's tummy and stimulate the baby to move. Whereas we want to make sure that this baby is good inside. That's the whole purpose of a non-stress test, is especially if mom is diabetic, especially if mom has gestational hypertension, maybe she has other problems, and she may have lupus, she may have thalassemia. And so you want to make sure this baby is doing okay inside, and that's how you can do it, which is non-invasive. It's an easy test, and it tells me a lot. Okay, so here I think I have a reactive test. So let me take my pointer. So see, I got a baseline here. See, here's 120. So this baseline looks like what? About 130, huh? Yeah, okay. And so here I have a lot of squiggly lines. So that means I have good variability. And so baby moves. See, here's her mommy pressing that buzzer, and baby moves. And look at that beautiful acceleration. So that's 15 beats above the baseline, and it's lasting more than 15 seconds. So I know it's good, because each box is 10 seconds. And then from one solid line here to this solid line is 1 minute. See? So it's 10, 20, 30, 40, 50, 60. See? Okay. So that's a good test. I would be very happy to have this lady. Okay. Again, we have fetal movement here, acceleration of the fetal heart rate. And here it's going 10, 20, and that's what? 25. Yeah. So you see, that's how we read it. All right. So that tells me my baby is doing A-okay. But here now, even just seeing this strip makes me feel sick, okay? Because I don't see any of those squiggly lines. I have very little variability. So it tells me my baby's sick. I don't have any accelerations of the fetal heart rate. Now, the fetal heart rate is at 130, but there's no accelerations, nothing. And no very, very minimal to absent variability. Okay, I got a little squiggly line. This baby's not doing well. So we consider this to be a non-reactive, non-stress test. All right. And we would go on to do a biophysical profile to find out what's going on with this baby. And a lot of times it could be due to low amniotic fluid, and we have to deliver the baby. So that's an easy way of knowing if the baby's in trouble or not. Okay, so let's go on. We're going to talk about gestational hypertension. Remember I said it happens after the 20th week of pregnancy. So it's hypertension. And when we talk about gestational hypertension, her kidneys are still functioning. So we don't have spilling of protein out of the tissue into the urine. So we're doing better, but we have to be careful, okay? We have to monitor her. And these kind of ladies do come in for NSTs. Now, if she gets a little sicker, the kidneys start to put out protein, then we go into what we call more preeclampsia. Now, preeclampsia is a pregnancy-specific syndrome. That means it happens only in pregnancy. It's hypertension that develops after 20 weeks of gestation. And this happens to women who normally are like normal, tensive women. They were fine before they got pregnant. And then at even the beginning of pregnancy, they were okay. But after 20 weeks, you started to see their blood pressures to increase. That's because they have vasospasming of your system. And so those spiral arteries start to get real spiral looking, and they have irritability. And then you get central nervous system irritability. So that's preeclampsia. And we want to keep it as preeclampsia because it can get worse. And we talked about all those warning signs, remember? Okay, so if it gets worse and she comes in, she's already seizing on you, now she has what we call eclampsia. This is seizure activity or coma in women diagnosed with preeclampsia. So when you have a patient that comes in to your labor and delivery, and she has hypertension, 160 over 110, she's hyperreflexive, okay, she's got blurred vision, you know, preeclampsia. So you want to get the magnesium sulfate in her very quickly, because magnesium sulfate will prevent seizures. Now, that's why we give magnesium sulfate, is to prevent a seizure, to prevent eclampsia. Now, HESI likes to put that on their tests because they want to make sure that you know the difference between preeclampsia and a patient getting sicker on you with eclampsia. Okay. So we want to prevent, remember nurses, we always prevent things from happening. So we want to prevent the seizure activity. Because once you get seizure activity, you get involvement of the brain. Okay. I think, and then let me go see where we're up to here. Okay. Let's just finish with hypertension and then we'll take a break. Okay. Chronic hypertension, just like it sounds, is chronic. It was there before she got pregnant, or it got diagnosed before 20 weeks gestation. Remember, preeclampsia is specific to pregnancy and it occurs after 20 weeks. Then you got your patients that, you know, in that first visit, you ask them, what's your medical history? And she says, well, I'm hypertensive. So now you have a condition of chronic hypertension in this patient. Can this lady get sicker? Sure can. She sure can. And that's why you have to be very careful with this one. Okay. So preeclampsia can go from mild to severe, and we get them on magnesium sulfate to prevent the seizure activity. We've got to be careful with the baby because we have to make sure that everything is perfusing. The blood, the placenta is putting out enough blood supply for the baby. Otherwise, you have uterine placenta insufficiency, and this baby will show up on your monitor as late decelerations. And so you have poor perfusion to the fetus, and then you can have that abruption with the placenta will abrupt right off the endometrium. And that's because the placenta is deteriorating right in front of you. Okay. And of course, you have poor kidney perfusion also. Okay. So just in case you see a question about HELP syndrome, it happens with severe preeclampsia. Your patient's really sick. Now, she's got that hypertensive, got high blood pressure, like 160, 110. She's got headache, blurred vision. Her urinary output is low, and she has epigastric pain, okay? This lady is very sick. So you're looking at the possibility of what we call HELP syndrome. It's a mnemonic for H stands for hemolysis, which is destruction of red blood cells. You have elevated liver enzymes. When you get epigastric pain, the liver enlarges. And that's usually the pain that she'll point like on her right side, right underneath her right breast, and say, I got this pain. They're really getting worse when they get epigastric pain. And then they can have low platelet count. that means they could be a free bleeder. And so, you know, you could have thrombocytopenia on top of it. Okay. So what's your care management going to be for somebody with this? Well, we're definitely going to be doing lab work and looking at urinary output. Definitely going to be looking at platelets, okay, because I don't want her to be like a bleeder. I'm looking at liver enzymes because, again, she has epigastric pain. And I'm going to look and see how much protein is being, you know, put out in the kidney, you know, through the kidneys in the urine. Because you're not supposed to have any protein in the urine, remember? Okay. I'm going to keep her on activity restriction. So we're going to put her maybe on partial bed rest, you know, have her on a layer on the left side. Healthy diet. Yeah, this is where we, you know, we got to make sure what she's eating, make sure she's drinking lots of water, and of course, avoid alcohol and tobacco and limit caffeine. Never good for blood pressure. Okay, I'm going to stop here at early pregnancy bleeding. Let me stop my share. And I'm going to, I know we've been talking for a while. I know I've given you a lot of information. So the time is, let me see, 3:48. So be back, say at what? 5 minutes after 4:05. How about that? It's a nice little break. Don't come off Zoom. You can come off your camera for right now, but don't come off Zoom so I can get your attendance at the end. And be back at 4:05 p.m. Eastern Standard Time. Okay? All right, guys. Take a little break because we got a lot more to go. All righty, a few more minutes and then we're gonna start up again. Hope it was a nice break for everybody. Ruth, how you doing? You look a little tired, Ruth. You okay? Okay. Hey, Chanel, how you doing? You had a little problems with your computer today, huh?
Yeah, I'm on the phone now.
Oh, okay. Good to see you. Okay, Claudia coming back. Everybody coming back. Everybody had a little break. All right, everybody went to the bathroom. Okay, we got a lot to do. So let's continue. Let's get your HESI book out, your pens and your paper. All right. We're just flying through. All righty, here we go. Are we back? Let me see my time. Oh, I got 2 more minutes. Anybody have a question? Anybody want to do a question?
I have a question. It's not about the HESI though. Well, it's
Yeah.
about next week. Do we have class next week?
Pardon?
Do we have class next Monday?
Yeah, how you get credit for your attendance next week is by taking the HESI.
Okay.
That's how you do your attendance.
So Monday we have to be on Zoom.
No, you have to take your
Okay.
HESI. What time is your HESI exam?
I think it's at 9 o'clock.
Okay, that's how I do your attendance. I go into the results. And let me tell you guys, start your remediation after your HESI, right after. Okay, you have to do remediation. If you do not do remediation, you get a 0 for your HESI exam result. Not good.
Do
I've
we
had
have
to
both?
I've
Do we
had
have
to do it
both
one
type of?
time. I had to do it one time. Student just didn't want to do remediation. Had to give a 0. That's worth 20% of your grade. You don't want to do that. So start your remediation right after HESI. You take it. All right. And then week 12, we do meet on Monday. We do meet. Okay.
So what we're gonna be doing on Monday? Week 12.
No, week 12, why are we meeting?
What we're gonna be doing on Monday?
Week 12, well, you get credit for your attendance, number 1. And number 2 is on week 12, I will send a schedule out. You meet with me for about 5 minutes, okay? And we go over some things and we come to the end of the semester. So you get credit for 2.5 hours for 5 minutes. Not bad. Okay, so I will give you a schedule out and you just come on to Zoom and you'll come in, you would be in the waiting room. And when I'm done with one student, I will let the next one in, okay? All right, that's week 12. If you don't show up for week 12, then you get marked absent. So that I wouldn't want to do that for a very short time on week 12. I wouldn't want to be marked absent for 2.5 hours. No way. Okay.
Okay, for the quick question for the HESI, are we expecting lots of quota questions?
Are you expecting what?
Quota questions, like the new
Oh,
gen
bow
question.
tie. Yeah, you could have a bow tie question. So you really want to know your material. That's why I'm going over everything with you guys. And always think, and you always keep in mind airway, breathing, circulation when you're answering questions. And do not please, how many questions? 50. Same, 50 questions. And do read the questions fully. And what do I always have told you guys to do? Look at the question and say, what's the question asking me? If you've been doing that, you could see, because you read half the question and you go, oh yeah, I see the answer, I do it. And then you get it wrong because you didn't read the full question. I've seen that happen. Okay, all right. Okay, I'm going to go ahead and let everybody put your camera on, please. And let's continue. Put your camera on. Okay, so I'm going to go over now early pregnancy bleeding. So what we got here is early. That means before less than 20 weeks. Remember, 20 weeks is your viability. So you've got early AB, which is your first trimester, which goes up to 12 weeks, right? Because each trimester is 13 weeks. All right. And it does depend upon if it's a complete. Let me go here. Let me show you right here. If it's a threatened abortion, AB, that means that there's some blood that's coming out. She might have even dark brown looking blood, and you have so you have a little bit of leakage. Okay, what you do with a threaten is that you put the patient to bed rest, and there's nothing in the vagina for at least 2 weeks. What happened was that between the implantation process, the the zygote or the fetus did not adhere, the bag did not adhere to the endometrium properly. And so sometimes you get bleeding, like right in here, you get some bleeding and they can slough off. That's a threaded. That everything is intact. The fetus is intact. Now, inevitable, you can see where the bag of water is broken, she's having bleeding. You can't stop this. She's wide open. See the cervix here? It's wide open. You can see the difference. Okay, so you can't stop this. It's going to happen. Now, this one incomplete is that the fetus was expelled, okay, but still a lot of fluid, a lot of blood still left up inside. So it's incomplete. All right. And then these are where it's complete, where everything, the fetus, everything's out, and then here's your miss. Now, with these, she has a DNC, that's dilatation and curettage. You have to evacuate the contents of the uterus so that it's all cleaned out, so she can maybe start again. Okay, so these would have a DNC. Now, if mom is Rh negative and she's having an AB, then you want to give her Rogaine because you want to protect the fetus and the mom and the next pregnancy. All right. So if you have what we call recurrent premature dilation of the cervix, that means the cervix keeps opening up. You might have to have what we call a cervical cerclage. Okay, and what we do is we actually sew up the cervix using the McDonald technique, and that works very well, actually. They can go up, they can do it 2 ways, vaginally or abdominal, and they go up and close the cervix up. Okay, that's because she just keeps, every time she gets pregnant, she goes ahead and dilates. And so we can go ahead and sew that up. And let me show you a picture here, right here. Sew up that cervix, and you can see it here. It does a nice job, and it works very well. So you got the patient on bed rest. You have progesterone. You have some anti-inflammatory drugs and some antibiotics. All right, but they can walk around. They can do well with this procedure, and they hold the pregnancy. Now, they hold the pregnancy all the way through. I had a patient that was doing non-stress tests on because we wanted to make sure this fetus was okay. So she got to be 36 weeks. And she said, I'm having my cerclage removed tomorrow, Irene, and I won't be back for another NST. So you can take me up schedule. I said, you know what? I'm going to leave you on the schedule just in case. They did remove the stitch. Excuse me. They did remove the stitch. And she did not go into labor, and she went all the way to 40 weeks gestation. It works. Okay, let's talk about ectopic pregnancy. So ectopic pregnancy, it occurs, most of them, 95% occurs in the fallopian tube. is mostly located on that ampulla, you know, when I talked about the ampulla of the fallopian tube. And it can occur in other sites, but 95% are in the fallopian tube. And what happens is that the ovum that became fertilized, it didn't implant inside the uterus like it should. It didn't make, sometimes it doesn't make it through the fallopian tube at all, and so therefore it stays in the fallopian tube like most of them do. So it's not good. And I think I have a good picture here. So here you can see where it can be other places, but most of them are right in the fallopian tube. And what happens, they get stuck. So here's the ampulla. And they get stuck in there and they don't make it through. Maybe she's got scar tissue. You know, remember we talked about chlamydia? And I said how chlamydia does affect the fallopian tubes. Well, there you go. It can make the tube very fragile, and the little zygote can't get through to get to the uterus. It has to get through to the uterus to implant. So what's she going to complain about to you? She's going to have severe abdominal pain. Then you have, maybe you have delayed menses, and you have abnormal vaginal bleeding. All right, so she calls your office, you're our triage, you're answering the phone, and she says, I'm having severe abdominal pain. And it's kind of low, nurse. I mean, it really is giving me a hard time. And what's the nurse going to ask her? When was your last menstrual period? Okay. She's at the reproductive years. And so her last menstrual period, she says, I think, nurse, it was like 8 weeks ago. Bingo. Okay. You send it to the hospital. She comes to the hospital, we do an ultrasound. And we find that the ovum is still in the fallopian tube. The fallopian tube, everybody, is thin. You know, they're not very big. You know, all these drawings you see makes them look like the tube is really big, but it's not. And it has to get through, see? And if there's anything in the way, it doesn't. It gets stuck. And so the cells don't know stop cell dividing. They just keep dividing. Boom, 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 boom. And so it keeps growing inside this fallopian tube. And that's when you can get pain. Okay. Now, you get her to the hospital quickly. She can get started on methotrexate. We give that through the IV, and that will break up those cells, and then it gets broken down and it gets reabsorbed by the body. It's gone. No more pregnancy. No more little fertilized ovum. Okay, it's gone. Now, if you didn't get her to the hospital in an expeditious way, and she had a rupture, she ruptured in the tube, then in this tube, she ruptures, then what happens is that the tube is gone. And so we have to remove the tube entirely. And so therefore now her chances of getting pregnant are going to be cut in half, okay, because she lost the tube. So that's why you want to be able to identify ectopic pregnancies very quickly. Okay, another problem that you can have early pregnancy is gestational trophoblastic disease. What it is the molar pregnancy. So another term you may see, hydiniform mole, molar pregnancy. Okay, what happens is that you got the fertilization occur, but it's not normal. So those cells that are supposed to keep growing and, you know, cleavage and start to divide all the way through, right? Well, the fetus, there is no heartbeat. It's not viable. There's just tissue. What it looks like, a cluster of grapes. And so it's not good. And so she comes in, say, for her 10-week or 8-week ultrasound, and you're going to put the ultrasound on her abdomen, and she's all excited, and then you find no heartbeat. That's a hydiniform mole. Now, what I want you to remember from this is that this could be precancerous with this lady when she gets older, okay? So we have to watch these hydiniform moles because they can cause problems. Plus, she cannot get pregnant for 1 year. All right, because the HCG levels on a hydiniform mole increase significantly. Okay, so HCG levels go up. Write that down. Okay, so they go up. It takes time for those HCG levels to go back down to normal. So we have to watch her for a whole year to make sure that it goes back down. So that's why she cannot get pregnant for a whole year. And to know that later in life, when she gets older, she could come down with a cancer, a uterine cancer. So it's unfortunately, it's very sad for somebody who's trying to get pregnant. Another significant finding to this hydiniform mole is that the uterus is significantly larger. So say she comes in, it's supposed to be only 10 weeks, right? So the uterus is just starting to come up into the abdominal cavity. But when you put her down to put the ultrasound on, she's way high. I mean, her top of her uterus is way high. Okay, she's much greater than 10 weeks. So therefore, you have a little clue right there. And she does have some bleeding. Now, a lot of them do pass spontaneously, but if they don't, then we have to do a DNC, and we just, again, go ahead and curettage and just go ahead and clean it out. Okay. Now, we have a couple of conditions, and this is late pregnancy bleeding. Okay, everything I described to you was early pregnancy bleeding, and now make another category for late pregnancy bleeding. So you got your placenta previas, okay, and so under previa you put in bleeding, but it's bright red bleeding. Okay, under previa for pain you have painless bleeding. And then for the abdomen when you palpate is soft. That's previa. All right. Okay. So that's part of late pregnancy bleeding. What happens is that the placenta, it implanted in the lower uterine segment. And you know, remember the osses, the internal os and the external os. Well, right over the internal os is covering. That's a complete previa. Now, it could be marginal, it could be low-lying, but again, it's painless, bright red bleeding. Okay. And let me see, I got a picture here. So see, here are your osses. See, this is the internal os, okay? And then here's your external. So this all protects the uterus and the fetus. So what happens is the placenta right here, it decided to be kind of down here covering the os. So more like a marginal here. Here and here you have the same thing. You have the osses, and here it's like, well, this could be probably marginal over here. And this is your low-lying complete. What I'm getting at is that the bleeding is going to be bright red. So when you're giving care to this patient, you don't put anything like your fingers up inside here because you can make her bleed. They can hemorrhage from this. Okay, another late pregnancy bleeding is called placenta abruption. So put the topic, placenta abruption, abruption placentae, and now you're going to make your columns. So on this one, the bleeding is dark red because it's higher up, and it's painful. It's pain in the abdomen and in her back. And her abdomen is rigid and board-like. It's like it's hard, like a board. So again, it's painful, and because it's abrupting off the endometrium. So it could be like maybe she got hit in the abdomen, maybe she has some trauma, and so it dislodged the placenta, so it breaks off from the endometrium. Okay, and when you have that, that's painful. Anything abruption would be painful. So And it's, you know, it's darker red because the bleeding was higher up. It was more higher up than it was low. Okay, with the placenta previa, it's low. So this is bright red. Placenta abruption is higher up. And so therefore it's dark red. Okay, but when I had a patient that came in and her fetal heart tones were in the 90s, and when I went to touch her abdomen, it was hard, it was board-like, okay. And I put the electronic fetal monitor on, and sure enough, I said the fetal heart tones in the 90s, and this lady was in a lot of pain. So we took her back for a stat C-section and got the baby out. Mom lived, and so did baby. Okay, so now we talked about UTIs already, and they're never good. And I think if you don't take care of this when she comes in it's cystitis, what happens is that it can go up higher and can go into the kidneys, and then you got a condition called polynephritis. And sometimes it does occur in the second trimester, and you have to put them in the hospital for IV antibiotics. That's why we check the urine for presence of WBCs or nitrites. We talked a little bit about trauma when we talked about placenta abruptia. It's never good because mom gets hurt and so does the fetus. Okay, and you know this occurs. You know that's why we worry about trauma to moms, because the condition placenta abruptia can happen, and so we want to make sure that we're on top of that. Okay, now another condition called hyperemesis gravidarum. Talked about this a little bit already because we talked about nausea, vomiting. This one is excessive vomiting, and you know she gets really dehydrated, so you have a terrible electrolyte imbalance. She can get ketosis and actually have acetone in her urine. You see weight loss, and this is significant weight loss. They come in, they can't eat, drink, nothing. Okay, they're very fatigued, and so usually we put them in the hospital with IV management, and then give them maybe some vitamin B6 and give them small portions. Okay, very easily digestive carbs, and then liquids between meals to avoid. Now, what we tell them too is to avoid distension of the stomach. When you have liquids, so like if I have somebody that I want her to eat, I'm not going to give her liquids before her meal. Okay, I'm going to try to get her to eat a little bit of food, right? And then after an hour after eating, then I may give her some liquids. Okay, reason why is because liquids can fill up the stomach, and it does trigger the nausea, vomiting reflex. And what happens is that she won't get the protein that she needs. So, and you do that with any kind of patient, really. All right, let's go into labor. Well, sort of go into labor, right? Nobody really wants to go into labor. They don't have to. But anyway, factors affecting labor. Remember the 5 Ps, or maybe you studied as 4 Ps. But anyway, here they are. We have the passenger, remember the fetus and the placenta, because they're connected. The passageway, which is your birth canal. The powers is the contractions. We talked about that. And the position of mom, that's the L&DP that we put in there. And then this psychological response. Very, very important. This lady looks like she's in what stage of the, what phase in the first stage of labor do you think she's in? Because she's smiling.
First.
Early. Late.
Yeah, she's in the first stage of labor. What phase? Remember those phases?
Is it late?
Yeah, the latent and early phase. Exactly. Good. Good for you. Good. Because she's smiling at you. Okay. All right. So in case you forgot about this, these are different positions. And I talked about this already, the occipital anterior, the occipital posterior. But all it means is the back of the head, the baby's head. In this one, occipital posterior, the back of the baby's head is to mom's back. So here's your position. Anterior, mom's front, posterior, okay? This is just right and left of mom's, how the baby's laying. Either to right side of mom or left side of mom. That's all it is. And so here, you can see where the interior of this baby's head is facing to mom's interior. So that baby would be in occipital anterior. And since it's laying to mom's left side, it would be left. And then here, same thing, occipital anterior, the back of the baby's head is to mom's interior. Okay, you can see where this is a more favorable way to have a baby, occipital anterior. And of course, mom has the gynecoid pelvis. Remember that? The gynecoid pelvis is the most favorable one for labor. Okay, is everybody okay on that? All right. And then we got some breaches. All right. So Mr. Frank breach, he's just exposing everything here. He says, I don't care. I'm gonna put my feet up by my head, and I'm in a Frank breach. So what's presenting is his buttocks, the sacrum. Okay. Now, where we have a single footling breach is one leg is coming through the cervix, and that, you know, these breaches, we do C-sections because, especially in the United States, because we, you know, there's just too many lawsuits for breaches. So we do C-section on Frank, and we do C-section, of course, on the single footling breach. And then you can see the difference in the complete breach. See how this baby's kind of wrapped, you know, everything wrapped up really nice and tight, where Mr. Frank, that's why I call this Mr. Frank, he's got his feet up by his head. He's just exposing everything. And then shoulder presentation just means that the shoulder of the baby's body is what's presenting. Okay, these do happen, but we do go ahead and we section for these presentations. Okay, now going back, just to go back real quick, we would never do an induction of labor on these patients. Okay, we would never. Induction of labor would be contraindicated for these patients. All right, you don't ever want to give Pitocin, do an induction of labor. Okay, so when I talk about dilation, this is what I'm referring to. So she's in true labor. She's going to dilate very nicely, as you can see in the chart. And also the cervix itself is going to get thin. So here you got a 0% effacement. Okay, that's like during pregnancy, that's okay. But as you see here now, see the difference between here and here? This is becoming more softer and it's becoming effaced. The cervix is now starting to what? To get real soft. When it gets to be 100% effaced, it's real easy now for her to what? Dilate. It makes sense. So that's what we say in true labor, that you have cervical effacement and dilation, opening up of the cervix. Okay, and remember, she has to be 10 centimeters. This is 10 centimeters. She has to be completely dilated in order for her to push. And that's going into then the second stage of labor, right? Okay. All right. Now here, remember I talked about this earlier. Here's your pelvis. Here's baby's head. Okay, here's your ischial spine, 0 station. Okay, these are really, the ischial spines are really prominent bony protrusions. You can really feel them when you go in to check. So when I'm going in with sterile vag exam, I'm going to go up and I'm going to check for dilation, but I'm also going to check where this baby's head is located. So first I go and figure out where my ischial spines are, and then I figure out if it's above ischial spine, is a minus. If it's below, that head is down here, then this should be a plus, +2, +3. So, you know, if she's in labor, she wants to bring, remember the head comes down and she dilates. And now this head will put a lot of good pressure when she's in labor on the cervix and help dilate that cervix. Okay. Now, if she's up here by -4, -5 station, we call that floating or ballotable, where we can put our fingers in and we can actually press against the baby's head, the baby will bounce up and he's not engaged. Okay, that's not a good sign. Okay, so let's go over the stages of labor, because I know HESI likes to put at least one question on the stages of labor, and you have to recognize it. So your first stage of labor starts when you have contractions, regular contractions, and you go to full dilation of the cervix. Okay, now remember, the first stage of labor is the longest stage. It has 3 phases, and we call that the latent, or the newer term is called the early phase. So they could have a latent or early phase. That's from 0 to 3 centimeters. So they're not going to ask you to, to describe, say from 0 to 3, because different books sometimes have different centimeters, but no, only from 0 to 3. They'll have a scenario, and they'll tell you that her dilation is maybe 2 centimeters. So then you know in your head that that's the latent or early phase, okay? So during that time, you wouldn't be giving her pain medicine. You want to get her acclimated to the room. Let her be up walking, and go over consent forms with her. She's usually very nice and smiling, just like that picture, okay? She was nice and smiling at you. Now, as she has regular contractions, she's going to dilate, and she gets more active in her labor. So now she's in the active phase, and that's from 4 to 7 centimeters. Okay. Now this is a good time to have that epidural. All right. If she wants an epidural. If she doesn't, and she wants what we call a non-pharmacological labor, that's fine. She wants a labor without medication. That's great. Then you're going to work with her and do the breathing and get her through every contraction. Okay. Now, the transition phase is from 8 to 10. This is where the contractions are usually about every 2 to 3 minutes. Okay, sometimes 2, lasting at least 60 seconds to 90 seconds in duration. Okay, and they're strong. Now, the transition phase, they're going to feel a lot of pressure, and you don't want her to be pushing before she's completely dilated, because when she pushes before she's completely dilated, she can make that cervix more edematous. Okay, so you want her to labor, to handle the labor contractions, to do the breathing. If she wants pain medicine, usually in the active phase is the good time to give her pain medicine. You don't give a patient a narcotic during transition, because transition, she'll go from 8 to 10, and then she'll deliver that baby, and the baby will be very sleepy at birth. Now, so that's how you manage your labor patient. And of course, your contractions I talked about. Okay. So now that was your first stage. So now she's completely dilated. And so she wants to push, and she does. She has a lot of pressure. If she doesn't have an epidural, she's going to feel the baby's head pushing down. Okay, it's a lot of pressure. She can push during the second stage of labor, because now she's fully dilated, full 10 centimeters. And so we start pushing, and that can last from anywhere from 30 minutes to 2 hours. Okay, we try not to go past 2 hours to get this baby out, because mom one will get very tired on you. It's a lot of work pushing maybe every 2 minutes, and then she's trying to rest and gets her breath and then push again. Is hard. So you don't want to get her too tired, because otherwise, if she gets tired, then you're going to need to have an assistance, such as a forceps delivery or a vacuum extractor. So you want to watch the timing of the pushing. Now, the third stage is the delivery of the placenta. Okay, placenta is so important, it has its own stage. Now, the placenta will come off with the contractions. She'll continue to have contractions. The placenta will break right off that endometrium, and she feels like it's another baby, actually. That's what my patients tell me. And they say, I need to push now, and they push the placenta out. And then your fourth stage of labor is your recovery. So usually lasts about 2 hours post-delivery of the placenta. And during that time, you'll take mom's vital signs, you check the fundus if it's firm, and you'll probably be giving IV medication such as Pitocin to make her contract. And you'll be on alert, hear this, on alert for any kind of uterine atony or atony of the uterus. You don't want her to have that, so you're checking what? The fundus. And I know in your discussion questions I read that you all learn a lot about the fundus of the uterus during this time. So there it is. It's a very important thing, because if he doesn't stay firm, guys, guess what? Your patient hemorrhages. And then she hemorrhages, she goes into hypovolemic shock. And then for hypovolemic shock, you can lose your patient. So yes, checking the fundus is very important in maternity. Okay. This is just a lever pole maneuver. This shows you the different positions of the baby. And I thought this was good to show you that this baby's in a vertex presentation. That means the head is down first. And it looks like this baby is OA. And so here, you're just, what your hands are doing is you're just going up here, and you can feel the baby's back. And then your other hand, you can actually feel like a little indentation right here. And you can feel that the legs. What we do this a lot for is we want to know if the baby's head, if it's vertex or she's in a breech position. Okay. So we do, that's what we use it for. All right. I'm going to go over this non-pharmacological pain management because it's usually a question about it. Because women will tell you they don't want any pain medicine. Because why? Because they have a sense that they can control their childbirth. Okay. Yeah, they're wide awake. They're not medicated. They've gone through maybe preparation for childbirth. Maybe they did the Dick Reed method of Lamaze or the Bradley, or they did all three. It's fine. They all are going into controlled breathing and control their body movements and diversion and all that. So you want to breathe with your patient. It comes down to it. Help her breathe. When she breathes too fast, she can get hyperventilated. All right, so write that down. Hyperventilation is never good. So we want, because patients can get feeling of what, tingliness and everything on it, and it's just they're very uncomfortable. So what do you do when you get a patient that hyperventilates on you?
Have them breathe in a bag or in the cup of their hand.
Yeah, exactly. Either, a lot of times in the little childbirth kit, preparation kit, they have a little paper bag. Put a paper bag over their nose and their mouth and just breathe. If they don't have that, take their hands, cup it over their nose and their mouth and just breathe normally, and that will reverse it. But it's scary to the patient. And you don't want to scare your patient during that time because she's trying to go for non-pharmacological. That means no pain medicine. Okay, so would hydrotherapy be part of that? Yes. Would effleurage be part of that? Yes. With going in the shower be part of that? Yes. How about getting on the birthing ball? How about sacral pressure, especially if the baby is in an OP position, using that lumbar sacral pressure, counter pressure, that helps the back. Okay. All right. If she does want pain medicine, remember you have to time it correctly. So you don't give it in the early phase and you don't give it in the transition phase. You give it in the active phase. Okay. That's when she needs it the most. But remember, opiates given do not take away the pain of the contraction. They do not. They give them during the rest time between contractions, allows them to rest more. So You give pain medicine, but she's still going to feel the contraction. But when the contraction starts to decrease, okay, goes down, then she'll feel more relaxed. But remember, it crosses the placenta barrier. So it means it's trans placenta. So it goes over through the placenta to the baby. So that's why you don't want her to be medicated during the transition phase, is because it will rate to baby and make baby very sleepy at birth. Okay. A spinal or epidural placement is really good for having pain medicine during the labor. This one actually takes the pain of the contraction away. She's anesthetized from like the waist down. So she doesn't feel her legs, and you got to help her, position. And you want to make sure, to write down epidural, you want to make sure you prevent hypotension. So you want to hydrate this woman before she gets an epidural to prevent blood pressure going down. When mom's blood pressure goes down, it makes the baby's heart rate go down, okay? So epidurals are good. You give them as they enter into the active phase, and it does help them with the contractions. They don't feel them anymore. And sometimes my patients went to sleep during the labor, and I had to wake them up to deliver. So it's time to push. So they do work. And this is just a diagram to show you back here, excuse me, of where we place it. Now, if they move during the placement of the epidural, they can create a terrible headache. Okay, and what happens is, instead of going into the epidural space, it goes right in nicks. It puts a little nick into the spinal canal, and cerebral spinal fluid can leak out a little bit, and it gives a terrible headache. Then we have to give her an epidural blood patch. And what we do, we take mom's blood, like a venipuncture, sterile, everything's sterile, and we actually take 10 cc's of that blood and put it into the epidural space. So you have to have the patient back in this position again, okay, on the side, and they put the needle in the back. We take mom's blood from her arm, and they go ahead and inject it right into that needle to create like a patch, and you can see it. And I tell you, as soon as you cover up that little puncture hole, okay, where the cerebral spinal fluid was leaking a little bit, the headache goes away. It works like a charm, okay? But you don't want to have a terrible headache after that. Okay. I think we went over the epidural pretty good. I'm going to skip over that one. And we're going to talk about a little bit about monitoring again. If mom's in labor, we are always watching fetal heart rate, okay? Because we don't, every contraction is like an effective contraction for dilation is like 50 millimeters of pressure, of mercury pressure against the fetus. So what happens is that his heart rate could go down because maybe he's having some problems in there, and so his heart rate go down. So we want to make sure the contractions are not too often. You don't want to create what we call uterine tachysystole, because what happens if you have too often the contractions, the heart rate will go down. So we want to have fetal well-being during labor, okay? That means we want to have the fetal heart rate in normal range between 110 to 160, okay? And we want moderate baseline variability. Remember those squiggly lines I showed you? That's what I want. That tells me my baby's okay, all right? And we want to make sure that the uterine contractions are not any closer than 2 minutes apart, especially, as you get into transition. You don't want them two every 1 minute, because the baby cannot take it. Okay. Now, you probably, I just wanted to show you this external monitoring. This is where we put the toco transducer, as you can see. This picks up the contractions. It's where is it located? On the fundus of the uterus. because that's the powerhouse. And that's what it is. And then you have the ultrasound transducer over the baby's back. See here? Over the baby's back. So as LPNs, you might be called in to put a fetal monitor on a lady. Okay, and so that's what you do. I don't think you'll have a question on internal monitoring. That's more of an RN, but LPNs can do external monitoring. All right. Now, remember real chart. Okay. So variable decelerations are just what we talked about. They vary in size and shape. They're caused by cord compression. That means the baby is either holding onto his cord, he grabs it, and then he lets it go. So when he grabs it, his heart rate goes down for a second, but he lets it up, he lets it go, and it goes back up. So variables, they have a sudden drop in their heart rate, but with a quick recovery back to baseline. That's caused by the cord being compressed. So what's a nursing intervention I could do? Turn it to a left side.
Turn to left side.
Exactly. So in a scenario in HESI, they might tell you baby's having variable decelerations. So you have to know that's cord compression, and want to know what would be your priority nursing intervention. So you have to read those questions very carefully. And but what you do is you get her, whatever position she's in, put her on her left side, because that's when you get better perfusion. So what you're doing is you're getting the pressure off the cord. Now, you may have early decelerations. Early decelerations are caused by head compression, where the head is coming down. So the head is coming down, and it's being, so the vagus nerve is being stimulated, so his heart rate is going to go down for a little bit, but then it comes back up as the contraction's over. So that is okay. I like early deceleration, especially in my patient's 8 centimeters. That tells me the head is finally coming down nicely. Now, accelerations are A-okay, guys. They're good. Remember, I showed you accelerations of the heartbeat. They're good. Now, she might need a little oxygen, may have it going, especially if she's in active labor, but usually accelerations are what we call A-okay. And then you have late decelerations. Remember we talked about the placenta and the uterus, perfusing and getting enough oxygen, enough blood. Well, if you don't have that and you had uterine placenta insufficiency, you have late decelerations. So there's your meal chop and your monitoring of your different ones. And here's a little, I put this also here for you. It's called veal chop. They usually maybe have one question on that. And then this just went over, I wrote out exactly what I just said. Okay. We already talked about baseline, and that's that time where we're looking at a fetal monitor strip, and it's an average of a 10-minute segment on the strip. Okay. Now, getting back to variability here, does this look good to you guys?
No.
No. So you can say equate this to an EKG on an adult. That's almost like a flat line. That's never good. Okay. So this is what we call absent variability. The beat to beat beats here. There's none. Okay. Okay. So that's never good. This baby is severely acidotic. Now here you have, see the little beats to beat, beat to beat. This is minimal, but at least you got something here. So it's like detectable, like less than 5 beats per minute. You have something, not very much, but you got something. Okay. Then you have moderate. And this is what I like. 6 to 25 beats per minute. See these little things? These are beat to beats. And there's quite a bit here. Good baby. This is a great baby. Okay. He's doing fantastic. Now this, Sorry about that. This one has marked beat to beat. So you have greater than 25. This you don't like too much either. What I like the most is the moderate. This one tells me this baby is starting to get into trouble, and could you probably use an IV, or mom could use some assistance. Okay, so your normal fetal heart rate is between 110 to 160. So if you have a baseline that's less than 110, that's bradycardia. Okay, if you have a baseline that's more than 160 beats per minute for 10 minutes or longer, that's tachycardia. Now, tachycardia can be caused by mom having an infection. If mom took any drugs, it would cause the baby's heart rate to go up. Maybe bradycardia would also be baby's in trouble, maybe mom's been severely dehydrated, and baby's in trouble. We got to get the baby out. So here you go. Here's some strips. So here's fetal tachycardia. Remember, 110 to 160 is our norm, and this baby's at what? 170, right? Yeah, 170. Okay, that's not good. Okay, so this baby's in trouble, and then it has very, very, look at hardly any blood beat to beat, right? It has like less than 5 beats per minute. Now this one here, down here, is bradycardia. Okay, so what's the baseline here? We're looking at a 10-minute segment. It's about 100. Okay, that's not normal. These babies cannot survive inside mom very long. Okay, they need to come out. They need to get delivered. All right, so here, when I talked about early deceleration of head compression, this is what you see. So here's your contractions. And remember, your contraction cycle is when you go up the contraction is called the increment. When you get to the top, that's called the acme or the peak. And you go down, that's a decrement. Okay, remember that contraction cycle? All right, and then here's your relaxation, and here we start again. Okay, now when we're looking at the baby's heartbeat with a contraction, you can see where the lowest part of this deceleration is called the nair. Write this down, N-A-I-R. That's the lowest portion of the deceleration. So the nair is happening at the same time as the peak. Okay, so this baby is coming down. So, and after the contraction, the heart rate goes up again, see? So he's doing good, he's okay. And then mom has another contraction. My head is, I'm coming down, folks. I'm gonna be delivered soon. And so he has it, so you can see. So you can see why when I said my patient, I saw the baby's heart rate start to do this kind of pattern. I said, oh, my baby's coming down. It's called head compression, early deceleration. That's okay. Now, this one here is called a late. Now, remember, late's caused by uterine placenta insufficiency. So here is your acme, and here is where the baby's heart rate goes down after the contraction. Now, what HESI does is it gives you a scenario, and it'll tell you that the heart rate decels after the contraction. Well, when they say after the contraction, that means a late deceleration. And that's uterine placenta insufficiency, and the baby, it cannot survive this. And you can see the beat to beat is hardly there, okay? Just maybe, look at these little, maybe just barely there, but baby won't last too long with this. This is called recurrent late, and it's just, you don't have, the baby's not getting enough oxygen that it should be getting. So that's not good. So that's a late deceleration. So that's how they'll put it, you know, in the scenario. Now this one is called variables. And remember, it's caused by cord compression. And just what I said, it varies. Okay, it's a rapid decrease, and then it's a rapid increase. Okay, so this is cord compression. These are variables. So you see sudden drop, rapid return, sudden drop, rapid return. And they have no relation to the contraction. They occur whenever they want to because they vary. All right. It's called quarter compression. So remember the mnemonic LION, L-I-O-N. You put the patient on the left side, you give an IV, give them some oxygen, usually about 8 to 10 liters, right? We use a lot in maternity, via face mask, but a tight face mask. Okay. All right, let's move on. Let's see. Skip over that a little bit here. We talked about the first stage of labor already, okay? When you look at amniotic fluid, you want to look at it and make sure it's clear, okay? Remember that. Amniotic fluid is clear and does not have an odor. If you see that mom has meconium, which is the baby's first bowel movement, and he's having it inside now instead of outside, that's not good. Meconium stain fluid. We can get through labor. We monitor very closely for meconium stain fluid. And now, if the amniotic fluid has an odor, that's usually indicative of an infection. Okay. Now, you could have a scenario on that, and they would describe it. You know, meconium. You have to watch the baby. Okay. We might even have to do maybe an amnio infusion where we dilute the meconium. But it's usually not good, but we can labor. If amniotic fluid has an odor, that means mom could have an intrauterine infection. Okay, because usually amniotic fluid is clear and odorless. So we watch. What are you going to do? Well, you're going to labor her. You're going to watch the fetal heart rate during labor for those amnio signs that we just went over. And we got to make sure she dilates, right? And that we can get this baby out as soon as possible. Okay. So your nursing care for the first stage of labor is really to make sure that mom, to get taken care of. You've got the fetal heart rate, like I said. You can get up and walk around if needed, different positioning, getting her up to the bathroom, making sure she gets an IV, and she gets some fluids in her and some ice chips, and make sure that the fetal heart rate is normal and that she's able to handle the labor pain. Maybe she's doing non-pharmacological, so you do hydrotherapy, massage therapy. We went over all that. And if she wants some epidural, then we talked about doing it in the active phase of labor. Okay, good. All right. And we talked about the second stage of labor already, so I'm not going to go over that again. Let's see here. This is called the Richen maneuver, and basically is just controlling the head, controlling the perineum as the head is delivered, and that's a control thing. They had it one time on HESI. Different episiotomies. You have the episiotomy that's raised straight down, which is the midline, and then you have the medial lateral. Cutting a surgical cut of the perineum to deliver a big baby we do it in order to deliver this head. It's better to have a surgical cut than a laceration, because a laceration it's just more jaggedy, and it's harder for them to recover. Okay, I'm going to skip over the video I have in here, episiotomy. You can look at that yourself. Second stage of labor, remember we got the lacerations. Lacerations can occur during the pushing, but you have to make sure that after delivery that if she has a trickle of blood constantly dripping, then she maybe have a laceration. Episiotomy, we do it. I have a video on that. And then you have the third stage of labor, where is your expulsion of the placenta. Just know what happens during each time, okay? And placenta, you can see, this is the shiny Schultz. That's the neonatal side. You can see the cord coming out, okay? I have a nice picture right here. This shows you the maternal side, which is called the Duncan. And I learned it as called the dirty Duncan. Okay, you can see the little lobes here. And then you have the fetal side, which is the shiny Schultz. Now, if any bit of this is missing, it needs to be reported to the healthcare provider right there at the time of birth, because we do not want her to have retained placenta fragments. That leads to hemorrhaging. Okay. The fourth stage of labor, she's recovering. And there you go. Okay. You always encourage the breastfeeding, and during the fourth stage is because breastfeeding increases the release of oxytocin from the pituitary, and it keeps her uterus contracting. So we have a reason for doing that. Okay, let's go over little APGAR scoring. Done at 1 minute and 5 minutes of birth. What it is a rapid assessment of how the newborn is responding to being delivered. That's called extrauterine life. 7 to 10 is a great score. Okay, it's good. The baby's doing well. 4 to 6, he needs moderate resuscitation, and 0 to 3, he needs a lot. Okay, he's not doing well at all. And I'll show you here. Let me go on here. So here's your care of the newborn. Here's your excuse me, radiant warmer, and baby will come out. Babies have to have a warm environment to come out. Definitely do. The thermal regulation is the utmost problem. Breathing too. Okay, so here's my APGAR score. So you have 5, 1, 2, 3, 4, 5 things you're looking at, like activity, which is your muscle tone, and pulse, the heart rate. And if he's moving, does he have reflexes? And then, and they call it by grimacing. And then appearance is your skin color, and then respirations. Okay, so this way you can remember it's called APGAR, right? All right, so the activity, does he have muscle tone? Well, if they come out and he's active, he's going to get 2 points. Nice baby. If he has a pulse, heart rate over 100, he gets 2 points. If he's grimacing, he has reflexes, reflexes, he gets a prompt, he's got prompt response to stimulation. So like, you kind of flick his little heel, a little bit, and he responds. That's great. That means neurologically he's intact. Appearance, skin color. Now, if he has a pink body and he has blue extremities, that means his hands and feet are blue. That's called what?
Acrocyanosis.
Good. Now, he gets a point, okay? Because my goodness, give me credit for my pink body. But he doesn't get completely all the points because he's not completely pink. Okay. And then respirations. Am I breathing okay? Do I have a nice good cry? I love when they cry at birth. Oh gosh, it's like music to my ears. Or is it slow and irregular and they don't give me my fingers cry? I do give them some points being at least slow, at least trying, okay? Because again, respirations is a big thing for them, and thermoregulation. So I thought this was an easier way to remember because it spells out. Okay, I use anything I can to remember. All righty. Now, I'm going to go into a little bit of preterm labor and birth. So we know that preterm is between 20 weeks and, 37 weeks pregnancy, okay? So remember, 20 weeks is your viability, and that's when a baby can survive outside the mom's womb, and 37 weeks is preterm. Okay, 36 and 6/7. All right. What you have to do is you have to recognize it quickly. Okay, so uterine activity, contractions. Is she contracting? And is she having cervical changes? Are these contractions, are they changing that cervix? I do not want her to go into preterm labor. So I'm going to try by giving her, now the same medication I use for preeclampsia, I'm going to use for preterm labor. Yes, magnesium sulfate, because it acts on the muscle fibers. of the uterus. So I don't want her to get too dilated, because what we found is that a patient gets more than 2 centimeters or greater, it's really hard to stop that labor. Okay, really hard. So I don't want her to go into labor. Okay, because the it's too soon for that baby. Remember, respirations is the toughest thing for the baby to handle, and when he's born, and if he doesn't have enough surfactant in his lungs, he's going to have really a lot of respiratory problems at birth. So I want to go ahead and get the magnesium sulfate going. Another tocolytic would be maybe terbutaline. Okay, that does increase the heart rate though, so be careful with that. So those are in indomethacin, that helps. It can help also, but the magnesium sulfate is the main one that we use. Again, it comes with, you have to be very, very careful with it. You have to check reflexes. All right, we've gone over chorioamnionitis already, but just know if she has a foul odor to the amniotic fluid, we've got probably some kind of infection inside the uterus. And she can have maternal fever, which would cause fetal tachycardia, like we talked about, and uterine tenderness. Not pretty. Okay, let's go. We went to preterm. We got to stop that labor, right? But now we got the other problem. We got postterm. Okay, so this means that the woman's uterus didn't start to contract. And so now we have a pregnancy that extends beyond 42 weeks gestation. That can cause problems too, because baby gets bigger. We call that macrosomic babies. You can have an increased risk for birth injuries. Placenta actually gets old. We talked about that. It gets calcified, right? And then we can have a decrease now in amniotic fluid called oleohydramnios. So we want to get these babies. So, when you get to be like 40 weeks, 41 weeks, 42 weeks, we're doing those NSTs, non-stress tests to make sure the baby is okay. Because, we don't want anything to happen, because everything, as I said, everything gets old after 40 weeks gestation. Now, mom can have a dysfunctional labor. You maybe have to do an induction of labor. You have to give Pitocin. She could have an injury due to macrosomia, which is a big baby. She could hemorrhage, an infection. All right, it's not a good thing. Let's skip over. You have dysfunctional labor. Remember those preceptive deliveries? Labor that lasts less than 3 hours. And what happens, you have those hypertonic uterine contractions, or we have that uterine tachysystole. Not good, okay? It's contracting like every minute. She can abrupt. The placenta can actually come off the uterine lining with a precipitous labor. And guess this, recent cocaine use can cause her to have precipitous labor. All right. Another thing we can do, if a patient comes in and she's breech, you see the sacrum here, you can invert the baby under ultrasound guidance and change position. All right, I've been talking about induction of labor, especially for post-term. We can do that Bishop score. And basically what we're looking at is criteria such as cervical dilation, where the head is, posterior is the cervix anterior, posterior. And we can look at that to see if she can be induced, okay? Now, induction of labor is putting her into labor before her own body does, all right? Let me tell you something, guys. Oxytocin is a high alert medication. It is so powerful that we give it in milliunits. You have to be very careful because you can abrupt the placenta. You can cause her uterus to rupture. And then she ends up with a cesarean. You can cause to have postpartum hemorrhage and infection. So, you can cause the baby to have lack of oxygen and be acidotic at birth. Okay. Now, another term that you might see is augmentation of labor. So what happens is that she started labor, okay, but she dwindled down. The uterus got really hypertonic on you, and she's no longer contracting. So then you would use Pitocin to augment her labor. That's called augmentation of labor. Sometimes we have to use some assisted birth. We have forceps, as you can see here. Sometimes we use it, especially if they have prolonged second stage of labor. We have to have assistance. Remember I told you labor, the push in second stage usually lasts about 2 hours. Well, sometimes they get so tired, we have to use the forceps. Okay. This can cause problems to the fetus, having some facial paralysis. So you can see the position of the forceps. They're made of steel. They have to position just right. Otherwise, you could have some facial paralysis to the fetus. Another way to get this baby out is to use negative pressure, and that would be a vacuum-assisted birth, all right? And these babies, sometimes they come out and they have like little hematomas. Basically, I'll show you here. See here? And they can have a collection of blood or a collection of fluid right here. That all goes away, but the vacuum extractor, and it's in a circular configuration, as you see. All right. And another way of having a baby is having cesarean birth. Okay. So you have your transabdominal cesarean incision. And we want to make sure that we get a healthy mom and a healthy baby. And so sometimes we have to do a cesarean. Doesn't matter. Like I always tell my patients, there's 2 ways to have a baby. Okay. All right. Now, if you have a vertical, goes right through the skin, right through the uterus, this is vertical. This is called like a classical incision right here. And then this is more of the horizontal, the flattened steel position. And basically that's like the bikini cut. All right. And I got some pictures in here you can look at. It's right in your book on cesarean delivery. All right. Let's see. You might have a question about VBAC. That's vaginal birth as a cesarean. What I want to emphasize on this is that you do not give Pitocin to a VBAC. All right. Because that's a weakness. When you have a cesarean cut, that's a weakness in the uterus. And so by giving Pitocin, you can make that uterus rupture. And so you never, ever, ever give Pitocin to a VBAC. We talked about amniotic fluid already, so I'm not going to go through that. Shoulder dystocia, the head is born, but the anterior shoulder sometimes cannot pass under the pubic arch. And so the newborn could have birth injuries. And we always want to not have birth injuries, but it can happen. And so if mom has complications, mom can hemorrhage. She could have rectal injuries. And the worst thing too for her is a vaginal hematoma. That usually a hematoma in the vulva, which is very, very painful. Very, very painful. Okay. Another topic I like to hit upon is the prolapse cord. When the cord lays below the presenting part of the fetus, as you can see, here's your cord. That is a medical emergency. And what happens is that sometimes the cord is real long. Sometimes baby's in a breech position. The bag of water breaks, the cord comes through. This is a obstetrical emergency, like I said, and we have to get the baby out. Rupture of the uterus is never good. That means the uterus now has opened up. Maybe she had a previous cesarean scar, like I said. That's why you cannot give Pitocin. She can never be induced because the incision could be weak. And so what you see on the fetal heart rate tracing, you see a abnormal, non-reassuring pattern. And so mom can go into shock. Okay. Amniotic fluid embolism is where the amniotic fluid, has a lot of kind of stuff in it, fetal debris, such as maybe meconium, languga, which is little hairs, Burnix, caseosa, could have that in the amniotic fluid, and it gets into mom's circulatory system, and it causes mom's cardiovascular system to completely collapse, and then she'll bleed out, and she can have hypoxia and low blood pressure. Very poor outcome. It can happen. Patients do die, and I've been on a couple that I lost my patient in that. Okay, postpartum. What you have to know about postpartum is how the uterus involutes. Involution goes back down to the pre-pregnancy state. It descends 1 centimeter every 24 hours. Some books say 1 to 2. That's fine. After she delivers, the uterus needs to be midline and at the level of the umbilicus. Okay. If it's above the umbilicus and deviated to the right, that means she's got a full bladder. Okay, you all got that. So we want to make sure that she is going back down to pre-pregnancy state. Now, you may have subinvolution, where subinvolution just means it's the failure of the uterus to return to non-pregnant state. So this could be because she went home and maybe she got some placenta fragments still in there. And so the uterus is not going back down like it should. Then she needs to come to the hospital. And don't forget your lochia. You have lochia rubra, serosa, and alba. So this time when she goes home postpartumly, you teach her that how it should progress. If at any time it reverts back, say she was serosa and now she's back to rubra, that's not normal. She needs to go back to the hospital because she could have retained placenta fragments. All right, let's go on. Here, I'm just showing you how to massage that fundus. I know you all know how to do that. Okay. Here, and I just talked about the serosa of the lochia, and you know that too. Okay, moving right along. Placenta hormones, remember, are now the expulsion of the placenta. So what happens, you have decreases in the placenta producing hormones. And estrogen and progesterone now, the levels will drop markedly. And your hormone that you need for breastfeeding is called prolactin. I put that down. Prolactin is the hormone that's needed for breastfeeding, and that will increase after delivery. Now, moms that have type 1 diabetes, they do require sometimes less insulin for several days after birth, and that's because of now the placenta is not putting out that little extra placenta glycogen anymore. So mom has a decrease in that, therefore she decreases her insulin. All right, urinary. Make sure that she's not bleeding excessively. You want to make sure the fundus is firm. I know you know that. Make sure that she's going to the bathroom. And if she's not, and her fundus is above the umbilicus, empty that bladder. They usually have a question about that. Breastfeeding. Remember, breast is the best. You have colostrum, has a lot of antibodies. It's rich. It's like a more of a yellowish kind of looking fluid. It's very, very good for the baby. Okay. If she's not breastfeeding, she could have engorgement. And you went ahead and put her on wear a tight support bra. You can use ice packs or even, bags of frozen vegetables, and avoid any kind of nipple stimulation if she's not breastfeeding. Okay. But we always try to encourage. After delivery, the blood, she might have a drop in her hematocrit and hemoglobin, and that's okay because she loses a lot of blood. But remember, she had an increase in the beginning, like 45 to 50%. That accommodates for this sudden loss of blood after delivery. What you have to be careful is the increased risk of a thromboemboli after delivery. And postpartum headaches, it could caused by gestational hypertension, stress, and leakage. I told you about cerebral spinal fluid, during that placement, either the spinal or the epidural. And so you have to, be on alert for that. Okay. Length of stay really depends upon the condition of the newborn and the mom. Okay. Newborns, though, have to have their PKU test done at least 72 hours after delivering. So usually they stay for that. And the reason why we do it either at 48 hours, 72 hours is because the baby has to take in some protein in order to determine if he's able to break down the fetal filane in the PK. And so we do that for that. Your physical needs, this is what we want to avoid. Prevention of infection. Okay. Prevention of excessive bleeding from the boggy uterus or uterine atony. Maintenance of uterine tone. Hey, I know you know how to do fungal massage. And the prevention of bladder dissension. Those things we look at. We want to promote comfort. We want to give good, if she needs some pharmacological interventions, we want to make sure she doesn't get fatigue. Make sure she gets all the information she needs when going home. Make sure that she knows how to take care of a baby. Make sure that she walks around in order that we prevent a venous thromboemboli, such as, she can have a DVT very easily. And so we want to make sure she ambulates. That's always a good question on HESI. Nutrition. You got prenatal vitamins and iron. Continue that for 6 weeks. Lactating moms, they need a little bit more. I usually get them to breastfeed on this because I say you can have 500 extra calories if you're breastfeeding. And they go, oh, that's a lot. Yes. We want to make sure that her bladder is good and she's voiding good. Make sure she knows how to do pericare. Make sure she knows how to wipe herself, and make sure that she knows how to apply a peri pad. We go over breastfeeding, promotion of breastfeeding. Now, if they are breastfeeding, they will have more uterine contractions. They get back in their skinny jeans a lot sooner because breastfeeding, remember, produces more oxytocin. Therefore, her involution process goes faster. Okay, it's great. And that's how I usually get somebody to breastfeed also. If she's not breastfeeding, then again, tight-fitting bra binder, put ice packs. For engorgement, they can use cabbage leaves, okay? And then, of course, we used to give drugs, but we don't do that anymore. Okay. If you it's getting slow, so I have a few more minutes, okay. Planning future pregnancies. Now, I know HESI always puts on at least one question on rubella vaccines, okay? So, if the woman is not immune, the vaccine is recommended. Now, she's not pregnant, okay? Because you never give a live virus vaccine to a pregnant woman, never. But if she's not pregnant and she's not immune, then yeah, let's get her vaccinated. She has to wait a full month before she gets pregnant, okay? So, and you do need informed consent. Now, say she's pregnant, okay? You're not going to give it to her. And you have to wait till after she delivers. And then you can give it to her after she delivers while she's in the hospital. She can breastfeed, okay? All right. Now, they always like to put at least one of those questions on the HESI. All right. Negative. They always will have an RH negative question. So if a woman is RH negative and she's got the RH baby, she has to get RhoGAM. Okay. So you get it during pregnancy, as we discussed, and also you get it within 72 hours after. What you're doing, you're always protecting, like when after you deliver and you give her RhoGAM, think about it. You're protecting the next pregnancy, okay? So, because RH negative and RH positive don't mix very well. What happens is the RH negative mom, she produces antibodies, that if the Rh positives come across, the antibodies will eat up all those beautiful baby's erythrocytes and cause the baby to be very anemic. That's never good. So remember, if she's Rh negative, she will get RhoGAM. Okay. Let me see here. Okay. Discharge. I think we already went over this, but discharge teaching, always signs of complications, how she takes care of herself, her medications, routine mother and baby checkups, and activities of daily living at home. Okay. It's always good to know what should be included in a discharge teaching. It's always a good question. Bonding. Bonding, the theory, it describes the feelings, emotion, behaviors toward the baby after birth. Okay. Is she looking at the baby face to face? Is she touching the baby? Is she calling the baby by name? How is the family doing? Now, attachment theory is how the child develops after relationship with his mom and dad. That's a little bit different than bonding theory. Bonding theory is right after delivery. How do we promote bonding? Skin to skin. Okay, skin to skin. Remember that. Okay, let's go on here. Let me see, and on to here. Hemorrhage. They do like questions on hemorrhage, and so you want to make sure that you know about hemorrhage and what causes it, and I know you know the frontal massage. If you need to go, it's 5:28. If we go to 5:30, if you need to
Yes.
go at the 5:30, you can go. And I'm just
I
continue.
can go now.
But it's 5:28, so you might want to stay until 5:30. Chantel, what do you need, hon?
Yeah, no, all I need to do is just put on some pants and I'll be
I
going.
can't hear you. I'll go get Layla. I can't hear you.
I can go grab her. Just give me like a minute.
No, finish class.
No, it's about to be done in a minute.
Are you talking to me or talking to somebody else?
Oops, I'm sorry.
Yeah, I think so. Okay, so I know it's getting tiring. You can stay with me. I will continue, or you can leave at 5:30. You can choose. Okay.
I had a question about the APGAR score.
Yeah, sure.
So I know that it say if it's over 100 beats per minute for the pulse. I was gonna say right. Yeah, for the pulse that's a 2. But like, what if it's like way too high? What would you rate that? Like, would you still put a 2, or what if it's like
you
what?
You do it too, but then you would chart it as tachycardia, and
Okay.
that would be abnormal. That baby probably is a sick baby.
Right.
I can tell you, if that baby was sick, he probably wouldn't have a good APGAR at all. He's already compromised in another way.
Okay. All right.
Or I could take your name.
Okay, I'm gonna finish. You can stay with me or you can leave me. Okay, it's up to you. But I'm gonna finish so that I can record this, okay? All right, so HESI always has a question about postpartum hemorrhage. Because it's a leading cause of maternal death worldwide, all right? It's life-threatening, there's little warning, and she can go rather quick on you. So you need to know that in a vaginal delivery, if she has a blood loss of 500 mLs or greater, you got a hemorrhage. If you have a cesarean delivery and you have a blood loss of 1,000 mLs after cesarean, you got a hemorrhage. Okay, so you know what to do. What are you going to do? You're going to check that fundus. Okay. I know, because hypotonia of the uterus is very, very bad. Okay, and so a lot of times for this type of situation, we give Mepigen for marked hypotonia of the uterus. And then you may have another problem with postpartum hemorrhage is a laceration. If she had a forceps delivery or a vacuum extracted delivery, she might have torn up high up in the vagina. So she may have more of a laceration. That would be and this is how I've seen it from HESI, it might be like a trickle of blood coming down. Okay, so I mean, it's just like a water faucet. Okay, the water faucet trickles the water, right? It keeps coming, it's continuous. All right, so that would be a laceration. Now, you might have a hematoma in the vulva area. That's because maybe you had forceps or vacuum, and or you had a big baby, macrosomic baby. Those can cause hematomas, which is a collection of blood in the vulva area, which causes unrelenting pain. Unrelenting pain. And then she might have, you might not think about this, but you know, having magnesium sulfate can cause your patient to hemorrhage. These patients that are on magnesium, either, you know, for preeclampsia, they're at high risk for hemorrhage. And then another reason too is retained placenta fragments. This is where the placenta adhered to the endometrium, and she didn't expel all that, and so now she's bleeding. That this one, she can go home with retained placenta fragments. Maybe she's doing okay in the hospital, but she goes home. And this is the kind of patient that you have to remember, teach the progression of how the lochia changes from rubra to serosa to alba. And she's now maybe in alba, and all of a sudden she wakes up and she's in a pool of blood. That's not normal. And that's because there's something still left up inside that uterus that needs to come down. I talked about inversion of the uterus. I talked about subinvolution of the uterus. You can read, I already talked about that. So early recognition is critical. You want to first step, evaluate how the uterus is contracting. Firm massage of the fundus and assess for bladder dissension. Okay, now here's your medications. And a lot of times they will have these drugs on HESI. You have Pitocin, Methogen, Cytotec. Yes, you can give that as a suppository. You have Hemabate and even prostate gel E2. These are all prostaglandins that are given. For uterine atony, they give Methogen, and I know that was, I think it was on your test. They give Methogen, but you got to be careful with Methogen because of the hypertension of the cardiovascular system. So you have to be very careful with that. You wouldn't give that to like a preeclamptic. Go over hypovolemic shock. Remember, the body, every body organ needs blood. Okay, so when you have a low blood, you go into shock. What you're gonna see first is you're gonna see tachycardia. Then you're going to see the blood pressure go down, and then she will get, you know, cold and clammy. And so you have to be aware that your patient can go into shock. And if you're going to make sure, this could be a good question too for HESI, is that if she goes has a severe blood loss and she needs blood, make sure you get a consent form for blood, and that is not against her religion. Another problem is throwing a PE, pulmonary emboli, and it's a major cause for maternal deaths. You have venostasis and hypercoagulation. And I tell you, cesarean section doubles the risk. Anytime that you cut into the body, you can cause an emboli to go up. So what are you going to see? You're going to see tachypnea, tachycardia, apprehension, chest pain. Yeah. And the Holman sign, I would definitely know that a positive Holman sign is an indication that the patient's having a DVT. If your patient complains of pain in the calf and the calf is warm to touch, then you need to call the physician and get an order for a venous Doppler study. Now, these are different postpartum infections here. Okay, and so we talked about endometriitis, which is an inflammation of the endometrium. You have wound infections. You can have a cesarean or a episiotomy can get infected if you don't teach her how to clean after every urination or bowel movement. She can have mastitis, which is an inflammation of the breast. It's not good. These are all different postpartum infections. Mood disorders. We talked about this, where you have mild depression or baby blues, guys. That's just being 80% of women experience that. It's just simple, a feeling of sadness. They may feel impatient, anxiety, restless, crying for no reason, and feeling of disappointment. Depression is more moderate. It's a moderate to severe form of depression. 10 to 15% of women experience a more serious depression, and it can last until a year or longer. So these women have moments of feeling anger or rage, anxiety, the uncontrolled crying, the lack of interest in newborn, and feeling of isolation and a fear of harming the newborn herself. You can have postpartum depression without psychotic features. Again, is more intense, is pervasive sadness. Now, we can have it where you can have the postpartum with psychotic features, that's postpartum psychosis, and they're worried about infanticide and what? Suicide. Okay. Let's talk really quick about the baby's transition to extrauterine life. Remember, the first period reactivity lasts up to 30 minutes after birth. The newborn's heart rate increases from 160 to 180. Decreases after 30 minutes to baseline. And infant is alert and has spontaneous startles, crying, and head movement. Perfect time. This is a good time to put the baby to breast. And then they go down to their second period of reactivity where they're tired, they're gonna sleep. And so that's a good time. That baby now goes to the nursery, and mom gets cleaned up in the LDR. So that's a good time for that. Okay. So the second period, I just kind of talked about that there a little bit, but between 2 and 8 hours after birth. Okay. This is where you can see it. The baby hopefully didn't have meconium inside and pass it inside in utero. This is where they could probably pass it now, because they're outside, they're extrauterine life, and they got now they have their first bowel movement. That's the first bowel movement is meconium. Now they're going to be moving around a little more, so they should have a little more muscle tone. They're changing the skin color. Now their little hands and feet are no longer blue. They get pink. You always have to be worried about suction in them because they have a lot of fluid yet and may have a lot of mucus. So you just got to be, watching them closely. Now, again, this is on the APGAR again. This is another way of looking at it. The other one I went over had spelled out the mnemonic APGAR, the word APGAR. Same thing. If it's absent on any of these, it's 0. Okay. If you have less than 100 on the heart rate, you get 1. If this respiratory rate is weak and irregular, they're going to get a 1. Arms and legs are flex, they get a 1. Grimace is 1. Remember, grimace is reflex. And the hands and feet are blue, that's acrocyanosis. They're going to get a 1 because they did pink up their body. Now, if they're perfect and you give a greater than 100, you give a 2. If they're coming out and they're good crying, very vigorously, they get a 2. If their body is well flexed, they get a 2. If they're coughing or sneezing, that's a reflex, they get a 2. And if their body's completely pink, they get a 2. Just know that you always want to always keep in mind the babies have trouble with their breathing and thermoregulation. So I'm going to, put the baby's skin to skin. That actually keeps them nice and warm. And I want to make sure the airway always stays open. And then cover with a nice warm blanket. That's what I do all the time. And I can always assess his heart rate through the cord. You hold your finger on the cord and you can feel the pulsation. And then make sure baby is having no problems breathing. If he's not breathing, then you'll have to ventilate. So that baby comes off mom's chest. And because babies lose heat very fast from their head, put a little hat on them. That keeps their body. Okay. So these are some different changes that occur in a newborn once he's out. I would just know that go over the normal newborn vital signs. But if you have periods that are slow and irregular breathing, then you want to look at that. If you see chest retractions, you want to find out what's going on with this baby. You want to make sure, because once the cord is clamped, it puts a rise in blood pressure, can cause increase circulation and lung perfusion. So again, once the cord is cut, they're on their own, right? I always say. Now, birth through the first 2 hours, you want to look at gestational age assessment. Is this newborn appropriate for gestational age? Is he large? That means he's over the 90th percentile. Or is he SGA, which is small for gestational age, which is below the 10% percentile. Those are things they look in the nursery. And then always, 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 airway maintenance is utmost. Maintain body temperature. And then you can give your interventions such as prophylactically, we put the erythromycin eye ointment in using a ribbon fashion. Now, I've seen HESI actually have this on their test. So it would be in a ribbon fashion. That means you put a little bit in, come back half, go forward. Okay, then you go back half, squeeze a bottle, go forward. That's called a ribbon fashion. And so you want to do the eyes, okay, because you don't want any baby to have an eye infection because maybe mom had an infection in her vagina. And so you don't want to have gonorrhea in the eyes. Okay. You usually wait. That's usually done like the first hour. Okay. I let the babies bond first with mom before I start putting the eye ointment in. And then as mom is now getting tired, baby is starting to get tired, I go ahead and put the eye ointment in the labor room, in the delivery room. Vitamin K, you want to give in the vastus lateralis part of the leg. Yes, because the liver is immature and babies have a tendency to bleed more. So you want to give vitamin K, and then of course promoting parent-infant interaction. Okay. Bulb suctioning. There's always a question about bulb suctioning. So you want to make sure that baby's airway is maintained through correct positioning, and usually on the back or side, and removing any mucus from the mouth and nose with a bulb syringe. Now, the main thing is not to go straight into the mouth, okay? You always want to go on the side because you don't want to stimulate the gag reflex. So that's always a good question. Remember, the mouth is suction first and then the nose. So what are your signs of respiratory distress? Well, respiratory stress, you see the baby, would be nasal flaring. You have intercostal, subcostal chest retractions, and you have grunting. Okay, these are signs of respiratory distress in the baby. Never good. Now, apnea is a sensation, is stopping of breathing for more than 20 seconds. Okay, that's not good. A lot of premature babies have problem with that. This is a slide going over the cardiovascular system, and we know about bradycardia, less than 100 beats per minute. We know about tachycardia, okay. Skin color just kind of reflects the cardiovascular problems. If your baby doesn't pink up the way it should, then you need to check out the cardiovascular system. What else? Well, blood pressure, I gave you the normal blood pressure readings. And how do you get pulse on baby? You always do apical pulse. Apical, A-P-I-C-A-L. Always apical pulse for 1 full minute. That's how you assess. Again, their heart rate should be between 110 to 160. Remember, this is cold stress in this baby, and we never want to cold stress a baby, because remember, when you make a baby cold, the baby's going to try to make himself warm. So he's gonna breathe a lot faster. So he's gonna have a lot of oxygen consumption. Okay. If they get cold stress and they're trying to breathe more oxygen consumption, then their respiratory rate will go up significantly. Okay. And what happens is you start to shut down their pulmonary system. Okay. So you have what we call basal constriction. And then that leads to decreased oxygen to tissues. And you don't want to do that, because when it happens is you can create this baby to be acidotic. So keep the baby warm. Because I talked about thermogenesis quite a bit. But they don't shiver like adults. So what they do is that they increase their breathing. And so, and a lot of, especially preemies, they don't have a lot of what we call brown fat that they can pull for energy for to warm themselves. So brown fat can be rapidly depleted. So with a preemie, they don't have very much brown fat. And so they have a hard time keeping themselves warm. So you don't want to cause this cold stress. With cold stress, the respiratory rate will increase, okay, because again, increased need for oxygen. Then the oxygen consumption and energy are diverted from the brain and the cardiac function, okay, because they're trying to survive. And then you have, again, you can jeopardize your pulmonary perfusion because of the ongoing basal constriction. And then you have a lot of excess fatty acids that can displace bilirubin. And then you have increased bilirubin, then you probably end up with jaundice. And then from there, you have too much bilirubin, you have jaundice, you can get brain damage from too much bilirubin. So you see, cold stressing a baby is never good. And then also, because we talked about this before, you can get baby can get hypoglycemic. That can occur. Just like we can have a baby too cold, we can also overcook a baby. So what we do, you know that radiant warmer that I showed you a picture of? It has like a wire that can be plugged in, and you put a little, like the shape of a heart, little patch, and you connect the wire to the patch, and it'll keep baby's temperature, okay? And the warmer will adjust itself for the baby. It's really neat. You can't overcook a baby that way. All right. The first void always should be noted because it's so important to make sure the baby pees and the baby poops, okay? Again, the first bowel movement is called meconium. And then as the baby feeds, the stools will change, and yellow stools are very common for breastfeeding. Now, this is just about the baby's reproductive system in the females. As we know, you're born with all your different amount of ovals you're going to have, and babies can get increased estrogen during pregnancy. Okay, so what happens is sometimes these babies can have what we call a vaginal discharge. Actually, during a little period, they have little bleeding. And that's because of the increased estrogen during pregnancy they receive from mom. Okay, it's not. Tell mom it'll stop. It's okay, because during pregnancy, mom's estrogen goes to the baby. Okay. So little girls may have what they call this pseudo meconic vaginal discharge. A male Um, they may have, the foreskin, circumcised foreskin. You have to be very careful with it. And if he's uncircumcised, you had to retract the foreskin. Okay. You may have some swelling of breast tissue due to, again, too much estrogen in pregnancy. It does go down. It'll be everything will be fine. Okay. This is a breech vaginal delivery right here. You can see how the buttocks sacrum that was presenting is very bruised. This is a face presentation. Okay. Baby comes down the birth canal the wrong way, malpresentations. Okay, I want to go over two very important things on the skeletal. You can have a capus sarcodemian. Remember the crown of the head, and you have a collection of fluid under the scalp. That's called the capus sarcodemian. If it's on, it does cross the suture line. Remember, it does cross suture line. The supple hematoma is usually on the side of the head, and is that's a collection of blood underneath the scalp. Now, both of these things will go down in time, okay? So we just have to give reassurance to the mother. Now, the supple hematoma does not cross the suture line. Does not cross suture line. Okay. This is a picture of a baby that was down the pelvis way too long. As you can see, the baby's head had to mold to mom's pelvis. But don't forget, it's very adaptable, the baby's head, the fontanelles, they have interior and posterior, the suture line, and it all has to come together, the connective tissue. So at least during the time that this baby was in the mom's pelvis, it kind of molded to her. It will go down. So here's a good picture of what I was talking about, the capus sarcodemian. You can see here the crown of the head. You can see the suture line here, and you can see the edema of the scalp. Okay, it's just fluid underneath the scalp. On this one, you can, as I say, it crosses the suture line. Okay, now this one is a picture of a supple hematoma. So you have the blood between the scalp and the skull and its periosteum. So you see by the side of the head, that's why I was pointing to the side of my head. You can see that the scalp, periosteum, and then you have a little hemorrhage, and you have the cranium. Okay, this is called supple hematoma. This is a collection of blood. Now, the problem with this one is that the body will reabsorb the blood into his system. It will increase his circulating bilirubin, will increase the chances of him getting jaundice, and will increase the need for him to have phototherapy. And then here you have another hemorrhage in the scalp, subgluteal hemorrhage. And basically, it's after a difficult vaginal delivery. All these can be like from a vacuum extractor, from forceps. And so that's why we have to be very careful during the process of delivering. Hip dysplasia. You can see where the folds are a lot different, okay? You can see where the legs here, one's higher than the other. Okay, and that's another form of a abnormality at birth. Let's go over nervous system reflexes. Usually they have a couple questions on reflexes of the baby, and they go over which one keeps the baby alive. So you think about blinking, sneezing, gagging, sucking, and grasping. And they also can cry and swallow and lift their head slightly when laying on their abdomen. But you think about it, these babies have to have these kind of reflexes in order to keep them alive. So there may be a question on that. The Moro reflex, we went over startle reflex, okay? Rooting, anything that touches the cheek, anticipation of food. Tonic neck is a postural reflex that's sometimes assumed by sleeping infant and in dancing. The baby is held up and his little feet touch a cold surface and he kind of lifts his leg up. It looks like he's actually dancing or prancing, but that's a reflex. Reflexes are an indication of the nervous system. So if they're born without being able to have these reflexes, then there's a problem with the baby. Now, we talked about jaundice, we talked about hyperbilirubinemia, we talked about phototherapy, okay? And babies that have jaundice in the first 24 hours after birth, okay, that's called pathological jaundice, okay? Physiological jaundice is jaundice that occurs like 3 days after birth, 2 to 3 days after birth. They're both bad. Pathological is the worst, of course, because there's something wrong with baby's liver. Hyperbilirubinemia can lead to hypoglycemia and also hypocalcemia. Okay, so what are you going to do for these babies? They're under phototherapy. Ultraviolet lights on the baby. Baby's naked, or except for maybe a little diaper to catch the feces or the urine, because that's how he gets rid of the bilirubin, is that it comes through the excretion. So you want to have a little bit here. You want to have his eyes completely covered. That's also a good HESI question, because you don't want to harm their eyes being under ultraviolet light. That's your treatment for, and you always want to make sure that we're under phototherapy is that they have plenty of fluids. Okay. From 2 hours after birth until discharge, you're going to be collecting specimens, maybe do a heel stick, maybe do a venipuncture, and maybe obtaining a urine sample. When you're doing urine sample, you're looking for metabolic disorders such as maple syrup disorder. And do a heel stick for low blood sugar. Also do for the Guthrie test, which is your PKU. When you do a heel stick, you never go through the middle of the foot. You always go on the outside. You can see the middle of the foot where you have arteries and you have nerves. So you never, ever. And that's a good HESI question too. And security. Security is the utmost. You can see the baby has a security band. Mom will have an ID bracelet. Baby has 2 bracelets on them, and the significant other, whoever mom chooses, will have the other. They have to all match, and this is high security for the baby and mom. We talked about doing the vitamin K earlier, and here is where you do the vitamin K injection. Is at the vastus lateralis muscle. Okay, you have to be very careful. Here's the picture of being given. Make sure that you go into that muscle. Pain. Neonatal responses to pain. They do experience pain. We have to assess their pain and they have to manage their pain. Here's a baby that's nicely swaddled and in a supine position. He's nice and comfy. He's warm, right? And he has a hat on him. Here's the bulb syringe to make sure that his airway stays open, patent. When you're discharge planning and teaching, you always want to go over temperature with mom. You teach them the normal respirations, feeding patterns. Baby should be peeing and pooping, will be peeing and pooping before they leave the hospital. How to position and hold the baby, and go over, maybe the little rashes that maybe baby gets and some clothing. Always make sure that the baby has a car seat. It's called car seat safety. Bath, you want to go over bathing with the mom. The umbilical cord care. Before they leave, we'll remove the clamp, and you want to make sure that she keeps it nice and clean and dry, and that she folds the diaper underneath the cord so that it can get to air, and it will eventually fall off. Well, we do teach some cardiopulmonary resuscitation, babies choking. Remember, choking is one of the lifesaver reflexes. Okay. Here's a picture of we're removing the cord clamp. Okay, there's the diaper, how the diaper is underneath the cord. Okay. Okay. Recommended infant nutrition. The American Academy of Pediatrics recommends infants be breastfeed exclusively for the first 6 months of life. Yes, and that's what we try to do, at least get 6 months in. But if mom tolerates it and mom wants to, they can keep breastfeeding, and then just basically like other foods can be introduced after 6 months. Contraindications of breastfeeding. Well, we talked about HIV. You cannot breastfeed if after tuberculosis and not under treatment. Herpes on the lesion on the breast, cannot breastfeed. And the problem with glycemia in infants, because the baby can't break down glycose. So what happens is that there's sugar in breast milk a little bit, and so that will not be good for baby. That's why she can't breastfeed. Of course, chickenpox or maternal substance abuse, you don't want that. And then some medications that maybe mom's on, maybe you wouldn't want to be breastfeeding. Again, breast milk is the best. The colostrum, clear yellow fluid, that usually lasts from day 1 to day 3. It's extremely rich in immune globulins. Again, babies only have passive immunities, so they get 1 month from their mom. That's it. So this way they get all these beautiful immune globulins through the breast milk, and that helps them fight off infections. Okay. And then again, breast milk has less fat. So what happens is that they don't spit up as much when they're breastfeeding like they do with formula, because they can digest it a lot better. Let's see here. When you talk about weaning, I have seen that on HESI before. You don't want to wean a baby off like the night feedings. That's the most comforting for the infant. So you would leave that to the last one. You start to decrease the amount of breastfeeding during the daytime. Now remember, when mom starts to wean the baby off the breast, okay, she can start ovulating, and therefore she could start again having periods and get pregnant again. Okay. Mom has to just, make sure you go over diet. She eats a well-balanced diet. She keeps away from caffeine, which includes chocolate, because that goes right, anything that mom takes in goes right to the breast milk, put it that way. Mom can have problems with engorgement. We went over that. Sore nipples. Sore nipples are never good. That's why you have to make sure mom knows how to break the seal when she's breastfeeding, so that you don't ever pull the baby off the nipple, okay? Because that could cause sore nipples, open nipples, and then therefore she can get infection, and then she gets mastitis, and then she can get very sick from mastitis, and then she usually stops breastfeeding. She has this, she cannot breastfeed on the breast that she has like a purulent drainage in that breast, because that's infection. You don't want to give that to the baby. So what you do is you pump and you dump. She can breastfeed on the opposite side. And always taking a nice warm shower before breastfeeding is always good. Helps to release those ducts. All right, so birth injuries. Birth injuries can happen during labor. Again, we want to always avoid breast injuries. And so ultrasounds can let us know if it's a macrosomic baby or hydrocephalus baby, any unusual presentations. And then you do a like a C-section. So what you want, again, you want to prevent a significant birth injury. If you have a big baby and trying to get him delivered, what happens a lot of times is that the head will come out, but the shoulders are too wide. So then what you have is you have to get this baby out, okay? So a lot of times you have to break the clavicle, as you can see here in this picture, the clavicle. And then when that's broken, that shoulder releases downward, and so you can get that. And that's called shoulder dystocia. But the baby does heal very well afterwards too. Neonatal infections. Remember, we talked about GBS, group beta strep. This is a really very aggressive organism, and 50% death rate in infants. That's why every woman is tested between 35, 37 weeks gestation. Mom gets antibiotics during the labor process so that baby can come through the vaginal envelope without being exposed to group beta strep. It is one of the most significant causes of neonatal morbidity and mortality. Septicemia, and the most common for the babies are pneumonia and leads to perinatal deaths. Babies can have bacterial meningitis. It's higher in pretermers, and then of course gastroenteritis. But how can we combat all that? Is by proper hand washing. All right. Some maternal infections. The torch complex starts with toxoplasmosis. That's a parasite that's found in cat feces. Then you have the other, remember it's torch, T-O, other, which other calls your hepatitis B, your HIV, parvovirus, and the West Nile. Your R is your rubella. The C is the cytomegalovirus, and the H is herpes simplex. All right. Drug-exposed infants, narcotics regularly cross the placenta barrier, as we talked about, and goes right over, crosses the placenta, and can also be excreted in breast milk. That's why, again, mothers who have taken drugs can't breastfeed. Okay, all right. So these are babies that look like this from smoking or even alcohol abuse. And at birth, they may be small for gestational age. They have small eyes and thin upper lip. Not good. Not good. Mothers that take in alcohol. Mothers that keep exposing their babies to drugs. A lot of times these poor infants, when they're born, they will experience a withdrawal. And so they may have problems with neurological, GI, the autonomic nervous system, and they may have to have, be screened for toxology. These babies are uncontrollable. They are crying all the time. And so how you have to do is you swaddle them very snugly. And that's all you can do really, because they're so hyper irritable. You have a quiet environment for them, and make sure they're wrapped nice and tight. And they have to basically go through the same withdrawals. It's terrible. We talked about hemolytic disorders. When mom's a negative mom and she's at risk when the fetus is positive. So here you go. So a lot of times HESI will put on either indirect Coombs test or direct Coombs test. So I highlighted this for you, is indirect Coombs test is performed on the mother before birth, okay? And then direct Coombs is tested on the cord blood at the birth. Then we know that if she's at risk, okay? So what are you gonna give mom? Give a Rogaine. All righty. All right, let's skip down here. Mothers, infants of diabetic moms, you may have a macrosomic baby, increased risk for birth injuries. Yeah, they're big babies. They have higher risk respiratory distress syndrome, and they could, remember I said type 1 diabetic, there are high risk for congenital anomalies. Nursing care management, adequate thermal regulation. Keep these babies warm. They might need some carbohydrate feedings if appropriate. It's all according to their glucose. You don't want the glucose to ever go down. Some books say 45, some say 40, but never below 40. I'm going to tell you why, because you can get into a problem of neurological problems. Okay. Always want to keep the baby from getting infections and nutrition. So these preemies may have to have gavage feedings. Moms can still give the breast milk, and then we put it into a syringe. And then don't forget, you got a tube that goes down the nose, down the throat, into the esophagus, and go into the stomach. And with gavage feedings, you always want to make sure that the baby is being able to utilize what you fed them. So you want to aspirate before feeding these babies. Okay. Premature babies are at high risk for infection, again, due to decreased immune system. We talked about that, and we talked about respiratory distress. Okay. These late preterm babies, these are babies born between 34 and 36 and 6-7 weeks of gestation. Again, they're also at risk for thermoregulation, hypoglycemia, hyperbilirubinemia, sepsis or infection, and respiratory function. They're really, all of them are high risk for all that. Now, the preemies are high risk for respiratory distress syndrome because they lack the surfactant that's needed to improve the lungs to exchange oxygen and carbon dioxide. So a lot of times after they're born, if they still have breathing distress, then we can give them surfactant through the ET tube in the NICU, okay? A lot of times I've seen that on HESI about surfactant. All right, let's just skip along here. I just showed a picture here of gavage feedings on a preemie. Here's a little picture of a little preemie baby here. He's being monitored. And again, we're about respiratory distress, hypoglycemia, hyperbilirubinemia. Make sure mom got Rogaine during pregnancy if that's also a factor. These are some associated complications that they can have. Don't forget pneumothorax. They can have bronchopulmonary dysplasia, especially if they get too much oxygen. So you want to have a little pulsimeter on them to make sure that they maintain 92% or above, and you can be very careful with giving oxygen on that. At least, always monitor. Postterm just means that they've gone beyond 42 weeks. And we talked about this already, but the main thing is to monitor these babies. And a lot of times these babies are big babies. So if they're big babies, they can have their increased risk for hypoglycemia. And you always want to prevent meconium aspiration. If they have the meconium bowel movement in utero, then you want to make sure that when they're born is that they get suctioned, okay? When the head pops out, they get suctioned so that we can remove the meconium as much as we can, because we want to prevent meconium aspiration syndrome. Okay. And the last thing I want to tell you about is I seen on HESI about the neural tube defects, so spina bifida, and the spine, the myelomeningeal seal on the spina bifida you can actually see, but these spina bifida occulta you cannot see. What you see is a little tuft of hair on the sacrum. So you want to be looking at that. Developmental dysplasia of the hip, we can see. And the club foot, you can see. Let's see, cleft lip and cleft palate. Those are, again, congenital anomalies. And also, hypospadias. I've seen this on HESI. It's a birth defect in boys where the opening of the urethra is not located at the tip of the penis. Okay, so it's usually like on the side or the back. And so what you want to do on those kind of babies is that they do not get circumcised, because that foreskin they will use to reposition the opening of the urethra. So I've seen that on HESI. That's why I wanted to include. Just to let you all know that this is a lot of information. And I have another HESI review that I gave you, which only has 100 slides, but this is very comprehensive. It had everything on there that you might be exposed to, that you did learn during the past 10 weeks. Okay, well, I give you all a lot of credit for staying with me. I really do. You all are great. And if you have any questions or you have a concept that you don't understand fully, email me. I am available all week. Okay, so that was very comprehensive. I agree. And the other one I
Yes,
posted.
it was.
Yeah, I know, Brandy. But that's HESI. HESI can be any of these things. And remember, just read the question really, really carefully. Okay. Friday, I'm gonna do some more, but Friday I'm gonna do more questions. So if you'd like to join me